We are live now, doctor.
Okay, so can we start the meeting, Nilesh?
Yeah, please go ahead, sir.
Yeah. So good evening, everybody. So thank you for joining us on this inaugural episode of Path to Precision, which is a series which is given to us by the YOSI Refractive Focus Group. So I'll just be sharing my screen now. So the Path to Precision series is brought to you by the YOSI Refractive Focus Group, which is one of the presidential working groups which is put together by the YOSI Governing Council. At the outset, I'd like to extend my thanks to Dr. Devakant sir and Dr. Nilesh sir for putting together these presidential working groups and giving each one of the executive members a chance to take forward each subspecialty. And also, I'd like to thank them for giving me this responsibility and putting me in charge of the YOSI Refractive Focus Group. So the Paths to Precision series is a series of webinars that aims to cover all the basics and the advanced topics of refractive surgery. So the Path to Precision series is basically aimed at young practitioners who are embarking on the refractive surgery journey. So it'll be about a 5 or 6 episode webinar. This specific episode will explore topics which are not frequently discussed, but are very crucial for the beginner refractive surgeon to understand well. So let us start at the basics. So why should I start refractive surgery? Is a question that you might ask yourself. So as we know, myopia is on the rise in the world. The prevalence rate of myopia is said to increase to 52% in the population by 2050. In India specifically, there is a variation from 3.6% to 36.5% depending upon the region that is surveyed. And this is under the age of 40. So this will be a target group, and all of these people are going to need treatment for myopia. Hyperopia is somewhat lesser diagnosed because of accommodation in the younger population, but we will see this need to be addressed in the older patients as they go towards the age of 40. So the statistics are quite clear. India is a young population. The age demographic is majoritively between the age of 21 to 64. So this is the age group which is working and they are economically important. And there is a thought among general ophthalmologists that yes, refractive surgery is basically cosmetic. But this is where I would like to differ. I would say it's not just cosmetic, but it is something that is going to improve a patient's quality of life. And you are going to treat a patient's vision in their most productive working years. And you're going to improve their quality of life and improve their confidence and improve their productivity. So yes, it's a very important vision correction procedure and not just a cosmesis procedure as many of us think it is. And you will have many patients walking into your private practice asking for glass prescription. And one of the first things they do is they ask you, okay, you give me glasses. Is there a solution to be glass free? And that itself can be a stepping stone and motivation to start your refractive surgery practice. Let's look at the economy. As you know, the GDP is getting better in India. There is more disposable income. People are able to spend more on luxuries. And they do spend more on luxuries that they do not need. Every second person you see walking around now has an iPhone in hand. So what does this mean? The patients are willing to spend on the latest technologies that will improve the quality of life. So what we have to do as ophthalmologists and refractive surgeons is to convince this population that refractive surgery can be a safe and effective method to correct their vision and improve their quality of life. Satisfaction rates are very high. One of the key indicators in the Prowl study showed that 95% of patients who got the LASIK done were quite satisfied with the procedures. These high satisfaction rates also are present in both lenticular extraction and in phakic IOL correction as well. The challenge we face as refractive surgeons is to standardize the outcomes and provide the results in accordance with industry norms. As we know, as results keep getting better and better, patient expectations are also higher. And the more they pay for a latest technology, the more the expectations are. So we have to meet those expectations. Of course, we can't play down the financial benefits. Of course, it will increase your practice's earning potential. All of us know that refractive correction is one of the most financially lucrative fields that you can be in ophthalmology. It'll also give you an increase in referrals. Maybe you treat the 25-year-old for a myopia who comes to your clinic, then he's going to refer his 70-year-old grandfather for cataract surgery to you. So yes, the word of mouth is quite powerful in this field. Another thing is, as we know now, all of us are struggling with insurance companies, where most of these insurance companies will shorthand us on reimbursements. It's very difficult to keep fighting with them, and it's very cumbersome and headache-inducing. The advantage of refractive correction is these patients will pay you out of pocket. Most insurances don't cover refractive surgery, so there is much less headache in dealing with insurance claims as opposed to cataract surgery in general. And refractive surgery, I believe, should be considered a subspecialty in itself and not just something that we do on a weekend to get more money. Getting consistent results in refractive correction will require a blend of meticulous workup, correct decision making, implementation of sound technology, and reproducible surgical techniques. So, this is what the series will attempt to cover. It will cover the most practical aspects and challenging aspects a refractive surgeon will face in his career and help them deal with it in a better way. So the Path to Precision series will now aim to cover all of this. We will begin with this webinar, a very basic webinar on how do you go about starting a refractive surgery practice. We'll then move on to the next one, which will be corneal refractive surgery, where we'll cover surface ablation and LASIK. We'll then move on to lenticle extraction. Then we'll move on to IOL-based surgeries, which will be phakic IOLs, and of course, refractive cataract surgery, in which cataract surgery itself is nowadays a refractive procedure. So the format will be the young YOC members giving their inputs on their experience with refractive surgery, and their expertise that they have gained along with the years of being a young surgeon. And the input and keynote addresses will be given by an established doyen in the field, whose invaluable expertise will, of course, help all the members in getting their career forward in refractive correction. With that, it's my pleasure now to introduce Dr. Sri Ganesh sir. Dr. Sri Ganesh sir is, of course, one of my personal idols in ophthalmology and a mentor to me as well. He is a chairman and managing director at Netradama Super Specialty Eye Hospital. I believe sir has about 10 branches now in and around Bangalore. He's a dynamic cataract and refractive surgeon, and he's been on the forefront of newer technologies for phaco and refractive surgery for the last few decades. Numerous publications in very renowned international peer-reviewed journals such as JRS and JCRS. He's been awarded the honorary FRCS of Glasgow. He's got many accolades to his name, and he's also an innovator. One of my favorites would be his innovation in the outcomes of femtosecond intrastomal lenticular implantation, where it is tissue addition for the treatment of hyperopia. So with that, I would like to conclude my presentation, and let's begin with the webinar. Uh, Dr. Sri Ganesh sir, would you like to add a few words before we start?
Thank you, Altreya, for that lovely introduction, and I'm honored. Yes, I have. I started my refractive surgery practice 30 years ago. Actually, when I started my practice, and I started with RK. So I have seen the entire evolution of refractive surgery from RK, PRK, LASIK, microkeratomes to femtosecond laser to lenticule extraction and phakic IOLs. So it's been a long journey and a lot of experiences, and I look forward to sharing my experiences with the young ophthalmologists. And I thank you very much for this invitation. And I hope my advice and inputs will be of use to my young friends.
Super. Thank you so much, sir. Can I have a quick word from the Governing Council, Dr. Nilesh, sir?
Thank you so much, and thank you first of all to put such a nice webinar. And I think you started that this is such a basic webinar, but you got the best guy to start with. Sri Ganesh sir is here, so you have set the benchmark quite high. And then we have our own Dr. Zan is also doing quite well. Dr. Nishant sir is here. You yourself are doing so well. So thank you. This will be a practical thing, and I think this we can replicate to other subspecialties also, how to start the subspecialty practice, because most of them, when they go in private practice, they start thinking that it has to be comprehensive ophthalmology and not super specialty practice. So thank you for starting this. All the
Super.
best.
Right. Thank you. So we'll just move on to the talks now. So it's now my pleasure to introduce my friend and colleague, Dr. Zain Khatib. He's a cataract and refractive surgeon practicing in Mumbai at Katib Eye Clinic and Perfect Vision Laser Center. So he's got many accolades to his name. He's got the FICO, MRCS, FAICO, and cataract and refractive surgery. He's fellowship trained in phaco and refractive surgery. He's a recipient of multiple international awards in ASCRS, ESCRS, and APACRS, AIOS. And on a side note, you must follow his YouTube channel, very practical tips. So with that, his first talk is very important. It's named Refraction for Refractive Surgery. So I know this is a very difficult topic to tackle, and I was just thinking who to give this responsibility to. Dr. Zain very kindly volunteered, and I'm very happy he took this, and I'm awaiting to hear this talk from him.
Thank you, Dr. Aditya. That was a very kind introduction, and you're rightly so. You've set the ball rolling with a esteemed keynote faculty for today, Dr. Sri Ganesh sir, and your initial presentation also was excellent. Regarding the importance and standardization of refractive surgery today. Is my screen visible?
Yes.
Okay. So thank you for the kind opportunity to present here. And so I'll be talking on something that appears to be quite basic, that is the refraction for refractive surgery. But this in itself requires a lot of understanding and brushing up of the basics that we have been doing over so many years, because refraction is something that probably when we were trained out of it, we used to do it the correct way. And as the years go by, things start sliding down, and with better machines coming in, our refraction skills kind of go down. But it is important for a refractive surgeon to primarily be good in refraction. And that is what I'll, try to cover up today. And one thing that is, extremely important when we talk of refraction for refractive surgery is that we must understand that it will be slightly different from your glasses refraction. Okay, so for glasses refraction, maybe if a patient comes to you every few years, you may find differences. But for the surgery point of view, our refraction should be very, very standardized, as should all aspects of refractive surgery be. Refraction specifically. So in refraction, we are talking about hard endpoints. Whenever we are talking about refraction for refractive surgery, our endpoints, when we are stopping that particular part of refraction, they should be well defined and they should have hard endpoints. We should have a standardized protocol. When I say standardized protocol, it means that if you repeat it 5-6 times, over the course of next few months, it should always come the same. I know it is difficult, but if you have that specific way of doing it, you should be able to achieve it. And this was a study conducted by Dr. Dan Reinstein, where they showed, almost 95% of all refractions among all optometrists and doctors at their hospital was within 0.4 diopters, which is quite high. So you need to achieve something like this when you are practicing refraction for refractive surgery. Let's talk about a few concepts here. Let's talk about cycloplagia versus manifest disaccommodation. So whenever we talk about refractive surgery, everyone says that you have to do a cycloplagic refraction, to get the accurate number. But actually, there's no point of giving a cycloplagic acceptance to a patient if he's not going to accept it post-surgery. How much ever you try, you need to have the disaccommodation of the patient to be manifested. And that is called as manifest disaccommodation. Meaning, even if the cycloplegia is different, you have to learn how to make the patient accept that refraction. And we'll be talking a bit more about this as we go ahead. We don't want to achieve cycloplegic refraction. We want to achieve manifest disaccommodation. When we talk about phoropter versus trial frame, for refraction, for refractive surgery, I strongly feel that a phoropter is very much needed. And you'll see why, as I explain later. Trial frame is something that, shouldn't be considered for refractive surgery to get those perfect outcomes. And of course, do it yourself. Ultimately, you are going to do the surgery, and the surgery depends on refraction. So how many of our optometrists have done the refraction before the surgery? You need to do it yourself. Okay, so what I am going to talk mainly about very quickly is my standardized protocols, which I have also learned from somewhere else, but that is something that I practice, and I am kind of try to stick to it. The main principles are you try to push maximum positive sphere and you try to push maximum cylinder magnitude. Okay, so this is the essence of how I do the refraction, and I'll try to share some tips of how it has to be done. So when we talk about standardized manifest refraction protocol, if we are doing it now, let's assume that we are doing the refraction. What is the starting point for the refraction? Okay, at what do I start? So some people may not be having optometrist, but I do have an optometrist. So my starting point is my optometrist refraction. I put that in the trial frame. But you can use, if you don't have an optometrist, you can use your autoref reading, or if you're good at retinoscopy, or if you have an aberrometer, you can use the refraction coming from there. uh, and that would be your starting point. And once you have that refraction in the trial frame, then you go to your first step, that is for each eye you do your monocular refinement. Okay, so with the starting point, you check what is the best corrected vision. So if you have the LED chart, you show all the lines right from top to bottom. It's important not to ask the patient only to read till 6 by 6 or 6 by 5 specifically. You should encourage them to read till whichever line your chart can show. If you have 6 by 4, 6 by 3, because distances may not always be fixed. You may have it, you may not always have a 6 meter. So till whatever smallest line they can see, you should ask them to check, and then you should start. The first step is to modify the sphere. So always try to push maximum positive sphere, okay, and minimum negative sphere. So how do you do that? For example, if you've got a refraction, say at minus 2.75 sphere, and the patient is reading the best line possible as say 6 by 5, you make that 2.75 as 2.5 and ask the patient, is this blurring the vision slightly? And if the patient says no, then your refraction shifts from 2.75 to 2.5. If they say it's blurring the vision slightly, you go back to 2.75. And just to see if they're accepting little more, you can ask them, you can change it to -3 and ask them, okay, are you seeing more letters with this? If they are not seeing more letters with the minus, then you go back to the standard refraction, that is your 2.75. Okay, so this is how you try to push maximum positive sphere. So you push positive sphere. If they are not accepting, then you go towards making it more negative. So this is your first step of trying to disaccommodate that the refraction. So once you have pushed maximum positive sphere, again you see what the patient is reading. And then the next step is to do your monocular refinement with cylinder axis and magnitude. Okay, so once you've refined the sphere, you go to cylinder. Now, the starting point of cylinder and axis, again, it could be your optometrist refraction, or it could be whatever you've got on your objective refraction. And you ask whether the patient, what the patient is seeing with that. If I see a good, well-defined bow tie on topography, and the axis is slightly deviating away from the axis of refraction, I like to change the axis first to the topography axis and ask the patient if they can see better with that. Most of the times, if you've got a regular bow tie and not much difference, that slight shift to the axis of topography helps the patient see better. So that is my first point. And then the actual refinement is done by something called as Jackson cross cylinder, or JCC. And this is why it is important to use the phoropter over trial frame, because you cannot use the actual Jackson cross cylinder for those 5 degrees of axis refinement. It's nearly impossible if you've used it anytime. So the one that is on the phoropter is much easier, where you can do small refinements of your axis. So always on Jackson cross cylinder, first you check for the axis, you refine it. I'm not going to go into the details of that, but then it's important you do the axis, and once axis is done, you go back to your magnitude. And once axis and magnitude are refined, you must remember that you should try to push maximum cylinder magnitude. So if you're using the phoropter, you'll always have the sphere as separate, and cylinder will always be in minus value. So you'll put maximum minus cylinder. And yeah, and just remember, if you're changing the magnitude of cylinder too much, if you're going 0.5 diopter cylinder, then the sphere changes by 0.25 in the opposite direction. Okay, so keep that in mind. Once you have refined the cylinder, you go back to your sphere check, and you again try to push maximum positive sphere, the same method that we described before. Once this is done for each eye, now the final step is to do binocular balancing and disaccommodation. Now, this is something that is really difficult. Sometimes it may take a lot of time, but this is your final step that you can disaccommodate the patient, and it is extremely important. It's a complex process, but I'll try to tell you how I have been following it in my clinic. So after you've kept both the eyes open and refined both the eyes, you fog both the eyes with 1.5. So you add the retinoscopy fogging in both the eyes, and then you ask the patient if they can still read 3 lines below the original line they were reading. So if they were reading 6 by 5, if you fogged by 1.5 both eyes, whether they can read the 6/12 line or no. If they can read that 6/12 line, that means they are still over minus and they need to be slightly more over plus. So how do you do that? You then cover each eye alternately, ask the patient to look at the 6/60 letter, and you ask if it is equally sharp in both eyes. If one is sharper than the other, then you add 0.25 diopter sphere more to the eye which is better until both are equally blurred. And once this is done, now you defog, remove the 1.5 and again ask the patient to read the original line they were reading before. And if they are able to read that again, now they are successfully disaccommodated. So this is something where binocular balancing helps to remove the residual accommodation. So that was some of the steps of refraction. When I'm doing presbyopic refraction, I rely a lot on monovision for refractive surgery. So I'll just quickly go through that also. I check each eye best corrected vision and refraction, as I mentioned before. Then I check the distance corrected, uncorrected near vision and best corrected near vision. This gives me the idea of how much accommodation that patient has. You'll be surprised. Some patients have a good accommodation in spite of being 50, 55 years. Based on accommodation, I decide how much monovision defocus I want to create for the near eye, anywhere between 0.5 to 1.5 diopters. I find the dominant eye, but I don't always do the defocus of the non-dominant eye. I do the defocus of either eye because not all patients prefer the dominant eye for distance. Some of them prefer dominant eye for near also. And once I see how much they are comfortable with, I'll check their binocular distance and near visual acuity with the monovision. If they are uncomfortable, then I'll reduce the defocus until they're comfortable. And then I tell them that this is what you will get after refractive surgery. Of course, they do get better than this because we induce some amount of spherical aberration, but I try to make them get the acceptance of monovision before surgery. So those were just some points related to refraction. I'll just share this with you. This is my own refraction, which the optometrist had done initially. I read 6/5 with either eye. But when I use the standardized manifest refraction protocol with pushing maximum sphere magnitude and cylinder magnitude, you see how the refraction has changed. This is what has to be entered into the excimer machine. And I have learned all these points from Dr. Dan Reinstein. And if you're interested in seeing a very good video, 4-minute on YouTube, you can go through this manifest refraction protocol by London Vision Clinic. It's a very good video showing how live the refraction is done. So thank you for your attention.
Right. So that was a wonderful presentation, Zain. I
Thank you.
think I could not have put it better myself. So a few important points to make here. Refraction for spectacles and refraction for refractive surgery are two different things. When refracting a patient for myopia and you're giving spectacles, we tend to undercorrect them a little bit because myopes by nature, they are used to a larger and blurred image. So if you give them the full correction for spectacles, many times they won't accept because it minifies the letters and they won't be very happy. Whereas for refractive surgery, you're trying to correct all of the myopia and all of the cylinder. So it's very different. And you must have standardized protocols in place. You can't have a random optometrist in your clinic doing doing refraction one way and another optometrist doing it in another way. Personally, we have 6 optoms in our clinic and only 2 optoms are qualified to do refraction for refractive surgery. The others only do it for spectacle prescription. And everyone follows a same standardized protocol, which is very similar to what Dr. Zain just mentioned. And you have to be able to refract a patient yourself. And personally, I also do retinoscopy. My optoms also verify the refraction with the retinoscopy. You have to understand the reflex and how the reflex neutralizes, and then whether you can push cylinder more in one axis. Then go ahead and do your JCC, followed by balancing the sphere or even doing a duochrome. Very important point that was made to me, I think around 2 or 3 years ago when I was speaking to Dr. Sri Ganesh sir outside the halls of ASCRS meeting. I was telling sir why I was finding some difficulties in getting my papers on refractive surgery published. Sir asked me, are you reporting results where you're correcting up to the last line? I said, yes, sir, I'm correcting all my patients up to 6.6. Then sir said, I didn't say 6.6, I said last line. So that's when I understood. Last line doesn't end at 6.6. It has to go right to 6.5, 6.4, even some patients even read up to 6.3 and a half. Just imagine you're correcting a myope for -5, okay, and for -5 they're reading 6.6, but he might have read 6.4 for 5.5, but you have entered only -5 in an examer, and your examer undercorrects by 0.25 or 0.5. Automatically, you're already setting yourself up for having a post-op residual error of 0.75 to -1. And then you blame the machine saying, oh no, my machine is undercorrecting. No, your machine is not undercorrecting. You've probably made a mistake in your refraction protocol, which is not standardized. So it's very, very important to standardize your protocol, and you must be able to refract yourself. Even if you're not refracting yourself, you must at least be competent enough in refraction to explain to your optoms how you want it done. So I'd like Dr. Sri Ganesh sir to give his views on this topic.
There was a very nice talk by Dr. Khatib, and I think he explained most of it. It's very important to kind of push plus. That you have to keep in mind. Push plus and see that you give the and the best corrected vision. So what is very important also is to use standard charts, and it's better to use a logmar chart than Snellen's, and have a standardized distance. Many of them actually don't measure that. So it's very important that you measure from the eye to the chart. And many times you will find that the distance is not standard. If the distance is not standard, again, your measuring your visual acuity itself is wrong. So first thing is how to check vision. Before refraction is your vision charts, how to check vision, logmar. Each letter you will have to give a point so that logmar is much more accurate. And if you want to publish your data, then you have to measure in logmar. You have to use standardized charts. You have to see that the distance is correct. You have to see that the illumination is correct. So all these things have to be standardized even before you start doing your refraction. The other thing I would like to add is we do a duochrome test. It is kind of useful to see whether the patient is undercorrected or overcorrected, and you can kind of up till 0.25 you can be accurate. So apart from using the Jackson's cross cylinders for cylinder correction, we also use the duochrome test, which is quite useful to avoid over minusing the patient. So we push plus, so that is very important. And we always do a dilated refraction. It may not be a cycloplegic refraction, but again, do a dilated refraction. Some patients you may have to do cycloplegic refraction. These are patients who have very active accommodation. Especially today, a lot of people use digital devices for a long time, and then they're kind of used to accommodating, and they go in for accommodation spasm. So these are patients typically when you're doing the auto-ref, you get a lot of different readings. Sometimes you get a very high minus, which is not what they're wearing. And this is because they're actively accommodating. And these are patients that I would like to do a cycloplegic refraction and a PMT, or at least a dilated refraction and then a PMT. So when you do a dilated refraction, you can also pick up, early keratoconus and, abrasions. Even with your retinoscopy, you can actually, if you're good at retinoscopy, then you can even pick up abrasions once you're an experienced refractionist. So these are some of the points that I wanted to add. But yes, it is very important to learn how to do refraction, because there's a saying, garbage in, garbage out. So if you put in the wrong refraction, then you will have wrong results. You cannot get your nomograms right. You cannot get your data right. So it's very important to standardize your visual acuity tests and your refraction before you even start thinking of doing refractive surgery.
Sir, what would you start with your refraction? Would you depend on a manual retinoscopy, an AR, or an aberrometer for the starting point?
Starting point, we always do an auto-ref. See, how it works is when the patient comes in, there's a general ophthalmology department where they just get their auto-ref, retinoscopy, and refraction done. And then if they're interested in refractive surgery, then they come up, we do a dilated retinoscopy, again, cross-check. And then the final refraction is done on the day of surgery. And because there are a lot of other factors also, because if you have to also check the ocular surface, topography, everything. If your ocular surface is abnormal, you can have a lot of changes in power. This is something that we see. So there are a few other things. If the patient is wearing contact lenses, then they have to be off contact lenses. Otherwise, you can have some changes which can again affect your refraction. So for soft lenses, about a week. If it's for semi-soft lenses, even it may be 3 weeks or even a month for the cornea to, if they have warpage, to kind of settle down. So these are all things you have to be careful. So we do the refraction thrice, and we have 3 people in our what we call laser techs, or the optometrists who do the refraction for refractive surgery, and all 3 of them, the protocols are the same, and they always get the same refraction, which may be different. We also check different from the people in general ophthalmology who do the refraction. And we also check their glasses, whether they're comfortable, what kind of power they're using. This also gives us an idea as to whether we are close to the refraction they are comfortable with, or whether there's any change in glasses, whether we need to kind of delay until the power stabilizes. So there are a lot of small nitty-gritties which you can kind of follow, but yes, you have to be very good at refraction to get good results. The abrometer does not give you, because again, see, there is something known as the Malakara notation where, the abrasions also can be represented in higher order abrasions, sphere and cylinder. So when you're actually doing the correction, when the abrometer gives you a kind of a refraction, it does not normally correspond very accurately. And the refraction also varies with pupil size. So you have to kind of be careful that you do it in a normal mesopic kind of a condition. Scotopic refraction can vary from a mesopic refraction. So these are all things that even with the abrometer, typically with the abrometer, you're covering the head with a cloth and you're measuring scotopic pupil, because you want at least a 6 millimeter pupil to, to get all the abrasions. And when you do an abrometry, the refraction may not be corresponding to what the patient is accepting. So it's very important. You can do the autorefractometer as a guideline. Then you look at the topography. Again, topography, cylinder and manifest cylinder may not match, especially if there is lenticular astigmatism. Now, some of the machines, they take the topography data and then correct it. But the thing is, if there is lenticular astigmatism, then the patient will have a residual refractive error, which again takes a long time to settle, or it may not settle. So my whole principle is to correct the refraction in refractive surgery and not the cornea.
Correct.
So you have to correct the refraction, and then sometimes your manifest refraction may not always coincide with your topographic cylinder, and that is okay because the patient has lenticular astigmatism. I've seen many cases like this, but you should always take the topo manifest cylinder and the cylinder and the magnitude of the cylinder and the axis as a guideline, and then check. But finally, it's the patient's acceptance, what he's comfortable with, because what you refract is basically the refractive status of the eye, but vision is more than refraction. So that is something that you'll have to understand. Vision is a complete comprehensive system which involves visual pathways, which involves cortical processing, association areas. So then this is what the patient is comfortable with. So
Right.
finally, it is the manifest refraction, subjective refraction, and then you fine tune it with your duochrome test, your cross cylinders, before you finally kind of decide what you're going to treat.
So I have a question here. Dr. Arnav is asking, post-op, if a patient has any residual refractive error, when should he check it, or when should he consider it as a correct value? I think that's what he's asking.
See, what we tell our patients is that, yes, we are not, see, many patients want a perfect zero. They ask also, will my correction be zero? So this is something that you have to be very careful while answering. So you tell them that the aim of refractive surgery is to reduce your dependence on glasses so that you can function normally. Okay, 6.6 is normal human vision. Some people have little more, some people have little less. And the accuracy of correction is plus or minus 0.5, which is what we get. I mean, almost 99% of our patients eyes are within plus or minus 0.5 spherical equivalent, and you will get this if in a standardized practice. So we tell them that yes, even after the surgery, we are just going to put glasses and check your best corrected vision. And you need to do that because most of them, after LASIK or refractive correction, they make them read binocularly, and if they're reading 6.6, then they say, yeah, everything is perfect, you're doing fine, and then but you will never get your correct data. So we always tell the patients that yes, there may be a small residual refractive error, but you don't need glasses for that. That's because the laser is very accurate, but we have no control on your healing. And healing varies from individual to individual, even from eye to eye. So there can be, plus or minus 0.5. And we will also check and tell you. And this is a very good approach which we use because even post-op at 2 weeks or 3 weeks, we check the refraction, we check the best corrected vision, individual eye. So then you get the actual data to refine your nomograms. And this data also is required for publication. And then you tell the patient, yes, you have a 0.25, but you don't have to wear glasses. You have 6.5 vision or 6.6 vision. You have a 0.25. So even if he goes somewhere else to an optical shop or this thing, and then they say, oh, you have a 0.25, he says, yeah, my doctor told me it's fine. I don't need glasses. Otherwise, if you tell them everything is fine, it's zero, it's perfect, and then they go somewhere else and they say, oh, you have 0.5 cylinder, then they get very upset and then come back and start, arguing with you. So this is the approach. I think it is a very scientific approach, and then patients do accept if you tell them that, you don't have to. And normally the refraction may take up till 3 months to stabilize.
Correct.
Especially with higher refractive errors, you can have epithelial remodeling, you have some amount of regression. With hyperopia, it's even more than myopia. So if you think that there's going to be a little bit of regression and healing, then you wait for 3 months before you do a correction.
Correct. So, the last question now, before we move on to the next talk. So someone has asked to shed some light on wavefront aberrometry on the recent Wavelight Plus and how it is different from manifest refraction. So I think this doctor is referring to the Alcon hype machine, which is now
Yes.
telling us about.
Let me tell you one thing. I have used all these machines. In fact, I have purchased 7 excimer lasers and 5 femtosecond lasers. So I think I've been through it all. It started with Zyoptics. I had a Zyoptics 50, then a Zyoptics 100, then I had the Visex Custom View, then the Schwind, and the Men 90. So I have seen it all. So Wavefront is a hype. Okay. Wavefront LASIK is a hype. It is a marketing hype. It is something good that you can market if you want to market the practice. But you should be, as a scientific person, you should know that wavefront itself is very dynamic. Okay, wavefront depends upon the tear film. It depends upon the pupil size. It depends upon accommodation. It keeps changing with age. It keeps changing with the time of the day. So wavefront measurements are not 100% repeatable. Okay, this is something that you should know. Whether you're doing wavefront with a Hartmann shack or with a ray tracing, you will have a variation. Repeatability is poor. Now, the new Alcon machine, they claim that they use ray tracing for the aberrometry. And ray tracing is more accurate. Of course, ray tracing can capture better. A Hartmann chart cannot capture irregularities as well as ray tracing. But even with ray tracing, again, it is not like 100%. What I believe is correct the refraction, correct the manifest refraction. Patient will be happy. Don't promise the patient, supervision 6.3 because you're doing wavefront. You will get yourself into trouble. Always with refractive surgery, under promise, over deliver, and you'll have happy patients.
Good. So thank you so much, sir, for the extensive sharing of your knowledge. So now we just move on to the next talk. So our next talk will be by Dr. Aman Agarwal. He's done his DNB ophthalmology from Shankar Nethralaya. He's currently a fellow in cataract and refractive surgery at LV Prasad Eye Institute in Hyderabad. He has also won the Dr. S. Kanti Mahamathanathan Endowment Award for Best Neuro-Ophthalmology Candidate at the diplomate of an NBEMS ophthalmology student organized by Shankara Netralaya in 2021. So Dr. Raman is going to speak to us about the very important topic of evaluation of a patient for refractive surgery. Over to you, Dr. Raman.
Thanks a lot for that introduction, and thanks a lot for providing me the opportunity. I will just share my screen. I hope my screen is visible.
Yes, sir. And go ahead.
Yeah. Okay. So I'll be speaking on the preoperative considerations in refractive surgery. And first we should see that in a study by Stephanie et al. Regarding the malpractice litigations in cornea and refractive surgery, it was found that the malpractice litigation was particularly high in the refractive surgery because of its high volume and elective nature of the field. And LASIK constituted majority of the cases. And the major causes that were cited were either unrecognized or ignored contraindications to surgery, or an unsatisfactory result, or if the surgeon promised the patient of 100% success, and if the patient had preoperative unrealistic patient expectation. So we can see that a thorough preoperative evaluation, including history and an informed consent, is absolutely mandatory before taking up a patient for any refractive surgery. So coming to age as a guideline first. So according to FDA, age more than 21 years is suitable for a refractive surgery, provided that the refraction is stable, while ages between 18 to 21 is relatively contraindicated because the stability of the refraction could be in question. Refraction was nicely introduced by Dr. Zain, so I'll be skipping that. What is also important to see in vision is that if the patient's BCVA is worse than 6/6, it might be indicative of an amblyopia, provided that other ocular examinations are normal. So this becomes absolutely important in preoperative counseling. And we should explain to the patient that he might not be able to achieve vision better than what he has achieved with his spectacles. But there is a catch here that high minus lenses can cause magnification effect, which can itself decrease the BCVA. And post refractive surgery, the patient might be able to read even better than what he was reading before with spectacles. So it is always better to under promise and over deliver. Coming to an important part of the systemic history. So diabetes is very important, particularly young diabetics, because uncontrolled diabetes can result in unstable refraction. Then patients who have or who are suffering from anxiety or depression tend to be less um, happy with the outcome of the refractive surgery. Patients who have a history of seizure, it is very important to have the seizure under control before taking up them for refractive surgery, because the laser light itself can trigger seizure on table. Then a history of keloid or an abnormal scar on the body is particularly important, because these patients can have exaggerated healing response after refractive surgery, particularly if a PRK is done. Then a history of collagen vascular disease and autoimmune disease is also important, because most of these are actually contraindications for refractive surgery. Then females who are pregnant or who are currently lactating should also not be taken up for refractive surgery because of the changes in the corneal hydration. The refraction tends to be unstable. Then drug use such as isotretinoin, because most of the young females might be suffering from acne or acne disorders, so they might be on isotretinoin. And it is known that isotretinoin can actually hamper the functioning of meibomian gland, because of which the tear film can also get altered. And so this can also result in alterations in our calculations, especially the topography. Coming to ocular examinations, so in brief, the ocular examination should be absolutely normal from anterior to posterior. It is very important to look at the lids as well, particularly the presence of blepharitis or a meibomian gland dysfunction, because these can be a source of infection, as well as diffuse lamellar keratitis. Presence of a pterygium is equally important, because a pterygium might cause difficulty in applanation with the suction cone. There can be incidence of suction loss. Then keratoconus, as we know, is absolute contraindication to refractive surgery. And a history of herpetic eye disease is equally important. And patients with uncontrolled glaucoma are not suitable candidates. However, patients who have a glaucoma which is under control can still be taken up for refractive surgery, particularly in high myopes where the disc evaluation is a little bit tricky. It will be good to have a baseline HVF and an OCT of the disc if we are suspicious about the disc damage. Then any other ocular condition that can limit the visual function also needs to be looked for. Coming to the investigations, which are absolutely mandatory before taking up a patient for refractive surgery. So the first and foremost is the optical biometry, which basically tells us about the various ocular measurements. And it also helps us to relate the refraction of the patient with the ocular measurements as well. Next most important is corneal tomography. So any refractive surgery is incomplete without a corneal tomography. There are multiple tomographers, but the one that I will be focusing on in this lecture is the pentacam systems. So corneal tomographers can help us to rule out an abnormal corneal topography, particularly the irregular astigmatism or an inferior superior asymmetry, or keratoconus, particularly the subclinical keratoconus and form first keratoconus. Tomographers also give us pachymetry, which is helpful in calculating the residual stromal bed, as well as the percentage tissue altered, which I'll be dealing with next. Then Bellin-Ambrosio enhanced ectasia displays a particularly important tool in Pentacam, which can help us in screening patients before taking them for refractive surgery. Now for phakic IOL, apart from the previous investigations, the specular microscopy also becomes important. While the endothelial cell density is age dependent, the minimum endothelial cell density which should be considered adequate for phakic IOL implantation is more than 2500 cells per millimeter square. Then we also need to look at the internal anterior chamber depth, which can be taken from the corneal tomographers itself, as well as the white-to-white calculation, which can be taken from the tomographer, as well as with the help of a digital caliper. So these both are important in calculating or sizing the phakic IOLs. So coming to the eligibility criteria for ICL, so or any phakic IOL for that matter. So phakic IOLs are usually recommended for patients who have an ametropia which cannot be corrected by cornea-based refractive surgery. Then an internal anterior chamber depth should be at least more than 3 millimeter for hyperopes and more than 2.8 millimeter for myopes. Then white to white, and the relationship between white to white and ACD has been recommended by FDA. So if the white to white is less than 10.5 or if it is more than equal to 13, an ICL cannot be implanted in that patient. Then as I pointed out earlier, endothelial cell density should be more than 2500 cells per millimeter square. Now, there are other investigations that are optional, such as Corvus ST, which gives us the corneal biomechanical analysis. A topolyzer can be used if we are planning on a topo-guided treatment. An aberrometry can be done for the ocular aberrations. And ultrasound biomicroscopy can also be done to look for the anatomy of the ciliary sulcus when we are planning a phakic IOL implantation. So these are two maps, one from Pentacam, one from OpScan. So we see that there are a multitude of colors on the output. So what do these colors mean? So on the curvature map, the hotter colors represent steeper part of the cornea. In other words, it means that the cornea is bending faster in those locations, while cooler colors represent the flatter areas of the cornea. Coming to elevation maps, so elevation maps are very important. In the elevation map, the raw elevation data of the cornea is compared to the elevation of the reference surface. So if the cornea is elevated more than the reference surface, those areas are marked in hotter colors, meaning that the cornea is elevated in those areas. While if there are areas of depression on the cornea as compared to the reference surface, these are highlighted in cooler colors. Coming to the pachymetry maps, so thinner areas on the pachymetry map are represented by hotter colors, while cooler color represents the relatively thicker part of the cornea. So coming to the elevation map, so this is the output from the quad map of the Pentacam, which shows the elevation of both the anterior and the posterior surface of the cornea. First, we should also look at the amount of area or the amount of information that is displayed for us. So as in this case, it is a 9 millimeter data from 9 millimeter of the cornea. Then there is a very small text above the elevation maps, which basically tells us about the diameter of the cornea or the data from the cornea that was taken to compute the size of the best fit sphere, because the size of the best fit sphere will depend upon the amount of data that is used to calculate it. And this size also determines the screening values. So for a best fit sphere, which was calculated with a diameter of 8 millimeter, the normal elevation values for anterior and posterior surfaces of the cornea are less than equal to 12 and less than equal to 17 respectively. While if the elevation values are more than 15 and more than 20 on the front or the back elevation map, these are very high risk values, and they might indicate an ectatic process in the cornea. Also, we should note that even if the elevation values are normal, any difference between the anterior and posterior should not exceed more than 5 at the same point. So which brings us to a very important concept of a Munerlin formula. So it is basically a formula that is used to calculate the approximate amount of ablation per diopter of correction. So it is given by T is equals to S squared D by 3, where T is the tissue ablated in micron, S is the optic zone diameter, and D is the dioptric correction. So if we take the optical zone diameter as 6 millimeter, so approximately for every 1 diopter of myopic ablation, about 12 microns of tissue gets ablated. Next, coming to the concept of residual stromal bed. So the residual stromal bed is basically the amount of cornea that is remaining after the laser vision correction has been done. So it is equal to central corneal thickness minus the flap thickness minus the depth of ablation. This is applicable for a LASIK, while in case of a PRK, the residual stromal bed would be the central corneal thickness minus the depth of ablation, because we are not making any flap in PRK. In the literature, it has been suggested that a residual stromal bed more than 250 micron is recommended. If in case we see that the residual stromal bed is on the thinner side, it is better to prefer PRK over LASIK. However, there is no safe upper limit of residual stromal bed, which guarantees that post-LASIK or post-refractive surgery ectasia won't occur. Next is a very important concept of percentage tissue altered, which was introduced by Santiago. So in LASIK, the percentage tissue altered is equal to the flap thickness plus the ablation depth divided by the central corneal thickness. So basically what it means is that how much amount of the tissue we are changing or altering because of the surgery itself. So it was found in the study that PTA is a very strong predictor of LASIK-induced biomechanical change, even more than the residual stromal bed or ablation depth. And any PTA which is more than equal to 40% carries a high risk of post-LASIK ectasia, even with a normal preoperative topography. And PTA less than 40% does not always mean that ectasia won't occur. So that is why there is no safe upper limit for that as well. In case of PRK, the percentage tissue altered will be equal to the epithelial thickness plus the ablation depth divided by CCT. And in case of SMILE, it will be equal to the lenticule thickness plus the cap thickness divided by the CCT. So these are the ways by which we can calculate the PTA in all these three surgeries. Now we come to the concept of enhanced best fit sphere. So this is what is used in the BAD analysis. So we can see that on the left side, this is a normal cornea, and in yellow, it is the best fit sphere that is marked. While on the right side, it is a cornea which has a keratoconic process going on. So because of the localized elevation in the cornea, the size of the best fit sphere also gets altered. So in this case, the best fit sphere will be steeper so that it best fits the keratoconic cornea. So because of this, the elevation difference between the reference surface and the apex of the cone will be decreased. So that is why it can actually mask an ectatic process as well. So here comes the use of the enhanced best fit sphere. So how it is calculated is that the 4 millimeter or 3.5 millimeter zone, which is centered around the thinnest corneal thickness location, is excluded from the calculation of the best fit sphere. So by doing this, we are actually now calculating the best fit sphere based on the remaining peripheral normal cornea. So because it is approximating the more normal peripheral cornea, so this conical protrusion, which was getting masked earlier, is now more exaggerated. So this is what is used in the BAD analysis or the Bellin-Ambrosio enhanced ectasia display. So basically, it combines both the elevation data with the pachymetry map and indices. It is useful in screening refractive surgery candidates. It can help us pick subclinical keratoconus and form first keratoconus as well. So I will not be going into the entire details of it, but what we can discuss here is the elevation difference maps, which is shown on the left side of the BAD map. So what data are we seeing here is the on the top, these are the elevation maps relative to the best fit sphere. These are the same that we see on the quad map. These are from both the front and the back surfaces. while the second or the middle one is the enhanced elevation map. So this is based on the enhanced best fit sphere, which I have discussed earlier. And the elevation values with relation to the enhanced best fit sphere are shown here. The bottom maps are the elevation difference map, which are basically the numerical difference between the enhanced elevation map and the elevation map related to the BFS. So what it shows is the amount of conical protrusion that gets exaggerated when we are using the enhanced best fit sphere. So this is very important while screening patients for refractive surgery. So I would like to bring a case of a 25-year-old male who was interested in refractive surgery. The refraction was stable and it showed a compound myopic astigmatism. So we can see here that the patient has a very high cylinder, and the tomographic analysis revealed that the cornea has with the rule astigmatism with a symmetric bow tie. When we look at the elevation values, we see that there are no abnormal elevation values in both the front and the back maps, and the distribution of the pachymetry is also reasonably good. Similarly, we can also see in the left eye as well that again the patient has an enantiomeric features, and it is actually a mirror image of the right eye with a symmetric bow tie pattern, and there are no abnormal elevation values in the front and back elevation map, as well as the pachymetry also appears reasonably good. Also important before we look at all these four maps is to look at the quality specifications as well. So in Pentacam, this quality specification should be okay, which means that whatever we are seeing is valid. And also we also need to look at the Q value. So in this case, the Q value, actually the Q value tells us about the amount of prolateness or oblateness of the cornea. So in this case, the Q values are reasonably good. Now coming to the bad analysis of both the right and left eye. So we can see that in the bad analysis, in the right eye, all the zones are green in the difference map, suggesting that there is no abnormal protrusion of the cornea. While in the left eye also, there is a small island of borderline elevation in the front map, but there is no abnormal elevation in the back map. So this suggests that this cornea is reasonably good and can be taken up for refractive surgery. But then we need to decide which surgery would be better for this. So if we take the example of the right eye, which had a refraction of minus 3.25 sphere with a minus 5 cylinder, so we can calculate according to the Munerlin formula on the approximate ablation, which will happen along the steepest meridian, because that will be the meridian where maximum ablation happens. So when we put the values together, we find that approximately 100 microns of ablation will be required for this cornea. And now we look at the thinnest location of the cornea, which is 541. So if we are planning to do LASIK in this patient with a flap of, let's say, 110 microns, in that case, we see that the amount of tissue that gets altered is about 38%, which is very close to 40%. So we are dealing with a very high PTA when we are planning for LASIK in this patient. So a better option would be a PRK, in which we are manipulating lesser amount of tissue, and the PTA is also lesser. Similarly, when we calculate for the left eye, we will find that PRK would be a better option than LASIK in this patient. Coming to second case. So this is a case of a 23-year-old male who was also interested in refractive surgery. He had a compound myopic astigmatism with a vision of 20/20 in both eyes, and the anterior segment examination was normal in both eyes. So when we look at the quad map of the right eye, we see that the patient has a Q value of minus 0.46 in the right and minus 0.56 in the left, which suggests that this cornea is slightly more prolate. Now coming to the curvature map, we see that there is an irregular keratometry with more of inferior steepening in both the right as well as the left eye. Then when we see the right eye in the front elevation map, there are no abnormal elevation points, as well as in the back elevation map. These are all within the limits of which can be acceptable, as well as the pachymetry distribution also looks good in this case. However, when we look at the left eye, the elevation values in the left eye on the front surface are normal. However, there is a very small island of abnormal elevation on the back map in the left eye. Also, correspondingly, the thinnest location of the cornea is also present in the same location where the abnormal back elevation is present. So in this case, if we look at the bad map, we can see that the bad map also suggests a localized ectatic process going on in both the right as well as the left eye, more in the left eye. So this patient is actually not suitable for laser vision correction. And what we might actually be dealing is maybe a case of a subclinical keratoconus in the left eye. So these patients should not be taken up for laser vision correction because of very high risk of a post laser vision correction ectasia. So coming to my last point, so what is most important and what was also pointed out by Dr. Sri Ganesh was that the surgery is for reducing dependence on spectacle, and it does not always imply a complete spectacle-free vision. And it is also important to discuss with the patient is that the surgery will neither cure pre-existing ocular pathology, nor will it prevent future ocular problems. Thank you.
Thank you, Dr. Aman. That was, very comprehensively covered all the pre-op examination. I would like to ask Dr. Sri Ganesh sir, apart from what he has, presented, would there be some other investigative modalities that you have in your practice today for laser vision correction?
Yes, we always look at the epithelial maps. I think it's very important. The pentacam is good. By the way, that was an excellent talk. So, well done, Dr. Aman. But the pentacam kind of overdiagnoses keratoconus because the sensitivity is about 67%. The specificity is very good. It's like 97, 98%. So if it says that there is no keratoconus, then there's unlikely to be keratoconus. But then many of these cases can be labeled as abnormal, which basically you may reject for refractive surgery. So the rejection rates are much higher with the pentacam. We use the MS39, which I feel gives better kind of an indication for refractive surgery and gives the epithelial maps. So, see, there is a misconception that keratoconus or ectasia starts on the posterior surface of the cornea because keratoconus starts basically the pathophysiology is fibrillation of the Bowman's membrane and then a weakening of the Bowman's membrane, and then the ectasia starts on the anterior surface. But because it is masked by the epithelium, you don't see it on the anterior surface, and you may pick it up first on the posterior surface. But actually, the keratoconus starts on the anterior surface, and if you look at the epithelial map, there is an area of thinning. You get a donut-shaped epithelial map. There is a thinning over the central area where the ectasia started, though the topography may actually be normal. So epithelial maps are important, especially for these early keratoconus. And the other thing I would like to point out is it's not only that, the PTA and those that you need to consider, and otherwise you would be doing PRK for most patients because you say, okay, it is safe, it can correct. But that particular patient who has almost an equivalent power of 8 diopters, again, if you do a PRK, the patient's satisfaction as such is not going to be too great because with PRK, again, there is going to be discomfort, pain for 2-3 days, and the healing is prolonged. And the higher refractive errors, you have a high incidence of regression and haze, and especially high cylinders corrected with PRK, we see that the cylindrical corrections are not that good. So probably you could, if the PTA is low, or if there is some kind of if your residual stromal bed is not too good, then you can consider phakic IOLs, which may be a better option and may give better correction and more comfort to the patient. Because finally, there are a lot of considerations when you're looking at refractive surgery. You also have to look at the wow factor, the comfort of the patient, the recovery time, and how long the medication has to be used. All this influences whether the patient will be happy and will kind of refer their friends and relatives. So these are also some of the considerations that have to be kind of looked into. Of course, surface ablations. In many places, surface ablations are becoming very popular because it's kind of almost idiot proof in the sense that it's very easy to do. I mean, even if there is even if it's like a early kind of a keratoconus or a little bit of irregularity, you don't have to break your head as much. But then finally, if you look at the patient satisfaction and outcomes, I think with PRK, again, the patient satisfaction is not as good as with LASIK or with SMILE. So many of the institutions, including ours, we have specific indications for PRK. We don't do PRK routinely. Even London Vision Clinic, Dr. Dan Reinstein, he doesn't do PRK routinely. But it has its indications, and when it's indicated, we do PRK.
Sir, any role of biomechanics in your practice as a screening tool?
Biomechanics, again, is like wavefront aberrometry. It's nice to talk about, it's nice to do research on, but again, reproducibility is not that great. Of course, in those borderline very early cases, again, it's like on the fence. You don't know whether it's a weak cornea or whether it is not. Of course, if there is keratoconus, then definitely it shows that the cornea is weaker. So I think biomechanics has not progressed to that extent where we can use it as a clinical tool in day-to-day practice. It's okay for as a research tool, but I would not take it on face value because repeatability also is not that good.
One last question, sir, before we move on to your talk. So a lot of youngsters, have this question about the isolated pachymetry value. So you said that you use MS39. So suppose your
Yes.
machine would show you a pachymetry of say 460, 470, and everything else to be normal. And then what would be your counseling for a small number? Would you then want to do a PRK, or would you still do the
See, like I said, I've been doing LASIK from 27 years. And when I started, there was no guidelines on residual stromal bed. We used to use thick flaps. The Hansatom had 160 and 180 flaps. And the residual bed probably was less than, the percentage tissue altered was probably more than 40% in most cases, because if you lift a 180 flap and then do an ablation, we used to treat even 12 diopters, 15 diopters. But many of those patients have not gone in for ectasia. So see, if ectasia itself is an abnormality in the cornea, it's a pathology. And if thinner corneas need not necessarily reflect that there is an ectasia. That is something which I want to point out. There are cases, in fact, my brother-in-law also had a -5. He had like a 460. And I did LASIK about 20 years ago on him, more than 20, 25 years ago on him. And he had a -5, and I think we used a 160 because that was the thinnest on the Handstorm. And it's so many years, his PTA was more than 40%, but he's fine, and his refraction is stable even to this day. So just thinner corneas are not basically, I think, a red flag. I give more importance to topographic abnormalities, to inferior steepening, to skew, the epithelial maps.
correct?
Thank you so much, sir, for your input. I think we'll move on to your talk now.
Okay, let me try to share the screen.
Okay, so
Uh,
So Dr. Sri Ganesh sir is going to speak to us about a very practical topic on how to start your refractive surgery practice. So as we know, it's not so easy now. As young practitioners, we might have to invest a lot of money into getting the latest technologies, diagnostics. So Dr. Sri Ganesh is going to give us
Can
some
you
practical inputs on how he started this journey and at which
can you
point
see
of
my
time
screen?
to buy certain equipment.
Yes,
Yes,
sir,
sir,
it's
yes, sir.
visible.
You can start.
Okay, can you see the screen now?
Yes,
Yes,
sir.
sir.
Okay, so I'm going to talk on setting up refractive surgery practice and then what you need to keep in mind when you're setting up refractive surgery practice. And so let us start with first what I call the refractive surgery mindset. Okay, so you have to develop the refractive surgery mindset, and this applies to all specialties of ophthalmology. Whether you are a cornea specialist, whether you are a glaucoma specialist, whether you are a cataract phacosurgeon, you should have a refractive surgery mindset, which the mindset is to give a good uncorrected visual acuity for all patients. Because sometimes, in different specialties, they don't look at this. I'll give you an example of a patient had glaucoma. He came in for glaucoma surgery, and a trab was done. And the IOP was controlled. The glaucoma specialist was very happy that the pressure is under control. He's off drops. Patient was unhappy because he had developed 1 diopter of cylinder against the rule after trab. And he was saying that I could see better. Now after the surgery, I'm not able to see better. And the glaucoma specialist could not kind of understand. He said that the surgery is so good and your pressure is under control. That was his primary endpoint. But he had altered the refraction, and the patient's uncorrected vision was worse than what it was before surgery. And the patient was unhappy. Even in retina, where when you do surgery for retinal detachment, you put a buckle, then the myopia increases. And though you may have kind of settled the retina, the patient may still be unhappy because his myopia has increased. So these are all reasons why patient may not be happy even if you have a good outcome in your particular specialty. So refractive surgery permeates to all subspecialties of ophthalmology, and everybody should have a refractive surgery mindset. Even the cataract surgeon, today it is refractive cataract surgery. You want to give good uncorrected vision, both distance and near vision, and you should have this mindset of giving it. So refractive surgery is not just limited to refractive surgeons. I think all surgeons in ophthalmology should have this refractive surgery mindset. Also, you need to look at customizing for patients' needs. So all patients may not be very happy if you give them, uncorrected 6.5 vision or 6.4 vision. Because if they are early presbyopic or just turning presbyopic and you correct their myopia fully, then they may actually be unhappy, and they may not be satisfied. You're happy, you say that you've got a perfect result, there's no residual refractive error, you have 6.5 vision, but why are you cribbing? But the patient, again, you'll have to look at the patient's needs. I had this very early in my refractive surgery practice. There was one lady who was almost 39, 40, who came in for surgery, myopia of about 2 diopters. And then I did the correction, and she had a perfect result, plano 6.5. But then she came back unhappy, saying that, doctor, I'm not very happy. I asked, why you got rid of your glasses? You're seeing well. She says, I'm a newsreader, and then I have to put up makeup. And then before I was able to see my eyelashes very clearly to put the makeup and, eyeliner, now I'm not able to see it. And so she was unhappy. So this is something that you need to keep in mind, that you need to customize for patients' needs. Ask them about their lifestyle, about their profession, what they do. Sometimes you may have to do a slight undercorrection or a mini monovision, and these are things that you need to keep in mind. So you have to develop this refractive surgery mindset of giving good uncorrected vision, customizing to patients' needs to see that they are happy and satisfied after the procedure. Now, before you start your journey of refractive surgery is a subspecialty. In fact, now they have started what is known as the World College of Refractive Surgery, where they want to put it as a subspecialty with a specific curriculum and training, so that the results and satisfaction after a refractive surgery is good. Because now we have a lot of weekend refractive surgeons. You may be a retina surgeon or a cornea surgeon. You don't really know how to kind of read topography maps or do a proper refraction. But then you have access to a laser. So like once a week, if you get a patient who's asking for it, you just take them and then just do it. Doing PRK is very easy. You just have to press the button, trans PRK, press the foot pedal, and it's done. And it's a good source of income. But then that is not refractive surgery. And these are the patients who can have problems. About 10% of patients are not suitable for corneal refractive surgery. You take them up and then you do something, and then they are very unhappy, they have problems, and then they kind of tell other patients that they're not good. And that's the whole problem. And then the whole refractive surgery gets a bad name. So training is very important. And of course, if you're very particular, you can do long-term fellowships. There are many institutes that offer long-term fellowships. We have long-term fellowships in phaco and refractive surgery, 1.5, 2-year fellowships, which you can learn everything about refractive surgery, see different procedures, because there are a lot of procedures in the armory of the refractive surgeon. It's not just LASIK or PRK. So you will have to kind of customize. First, you'll have to learn how to evaluate a patient, then look at the patient's needs, and then offer him the safest procedure, which gives him the best correction, which makes him happy. So you have PRK, you have LASIK, you have SMILE, KLEX now, you have phakic IOLs, and so many other things, Presbyon for presbyopic patients. So with a long-term fellowship, you will get into the specialty of refractive surgery, and then you will be mentored in refractive surgery, and then you learn everything about refractive surgery, all the procedures, what it offers, and then you can decide and practice refractive surgery as a subspecialty. There are also short-term training programs. Suppose you're a general ophthalmologist but want to do refractive surgery, then you have access to a machine. Then the short-term training programs, which can range anywhere from a week to a month, where you can learn everything about evaluation of a patient, reading a topography, choosing the refractive procedure for the patient, and also get some hands-on and do some wet labs. There are also specific workshops for skill transfer. We actually run a course with Zeiss once a year, where we have a 1-week workshop which covers everything from PRK to phakic IOLs with wet labs and diagnetics, and also some hands-on. And this is like an introduction to refractive surgery, and then you will know all the details about patient selection and how to go about how doing a refractive surgery. You can also do wet labs and conferences. Many of the companies in their stalls offer wet labs, so you can try your hands at the wet lab, see if it is something that you like, whether you want to take up refractive surgery. Of course, attending seminars and webinars like these will give you an introduction to refractive surgery and some amount of exposure, because refractive surgery is not taught in most residency programs. And that's a pity, because it has so much of scope, because there's a myopia epidemic, like Aditya was saying, and by 2050, 50% of the world's population will be myope. So there's a huge opportunity for refractive surgery and for catering to patients. And also it's a very lucrative subspecialty. And so that I think it should be introduced, at least a part of it, in your undergraduate and postgraduate courses, because postgraduate courses, most of the postgraduate courses have no exposure to refractive surgery. So you have to get some amount of training in refractive surgery before you even think of starting a refractive practice. Then coming to equipment itself. Okay, so the first thing is you have to hone your refraction skills, and Dr. Khatib gave an excellent talk on this, on how to do proper refraction, because refraction for spectacles is different from refraction for refractive surgery. You need to hit the nail on its head. You have to hit the bullseye. For this, your refraction has to be very good. You should know how to refract, standardize your refraction protocols, and so that you can kind of give good results. So that is something that you should start off. Then learning corneal topography or tomography is very important. Whether you should invest in a tomography or a topography, that's again a big question mark. It depends upon how many patients you're getting for screening. If you have a lot of patients who are coming for screening and you're doing at least about 10 cases of corneal refractive surgery, if you're even taking them elsewhere and doing the cases, then probably it's worthwhile investing in a topography or a tomography. If you're just seeing 1 or 2 patients a year, then you can just refer them for a topography and learn how to read topography and tomography maps. Is tomography a must? Because again, now wherever you see the refractive surgery programs and webinars, everybody's talking on the pentacam, and it's almost become a standard. A pentacam costs about 34 lakhs now, and that is a huge amount for a young ophthalmologist to be investing, because you can charge only about 2,000 or 3,000 rupees for doing a tomography, and you can never recover that kind of money unless you're doing a good volume of refractive surgery. It's probably more prudent to have a topography system. You can have a Placido system, a simple system which costs about 5-6 lakhs with a pachymeter. And majority of the cases of ectasia you can actually pick up on corneal topography. I would say even if you are very good at retinoscopy, you can pick it up. You see the scissoring, very early scissoring, and you know that the reflexes are poor. And you should have a suspicion. Topography, if you have inferior steepening, skew, steep corneas, then these are all conditions where, and you have many of the devices have a lot of the indices, so you can learn how to interpret the indices, and then you can, because we started off without tomography and we just had topography devices, Placido based reflector graphs, which basically gave us anterior surface curvature maps. And if you want to kind of highlight an area, you can easily use a tangential map. Of course, the bad map kind of gives you elevation maps, and then you can use the bad algorithm to kind of pronounce the elevation which is there in keratoconus. But even on corneal topography, if you just have a Placido and if you use a tangential map, it will give you a little more information. And those small areas where you have steepening or depression, they get kind of enhanced. So you should learn how to kind of use a corneal topography and interpret corneal topography. And tomography, of course, is additional benefit because you can see the posterior surface of the cornea, you get elevation maps, and you get thickness maps, which give you additional information. But again, you should be careful in investing, because you always have to look at your return on investment as a young ophthalmologist. Otherwise, it would be an overkill to get a tomography if you don't have enough patients. Pachymetry again is important to assess things like residual stromal bed and percentage tissue alteration. So having an ultrasound pachy also works quite well. To start off with, you can, it's less expensive. And if you have a OCT, then many of the OCTs nowadays, if you're going to invest in an OCT anyway for your cataract practice or your retina practice, medical retina practice, then you can have an anterior segment OCT. Many of the anterior segment OCTs nowadays also give you some amount of corneal topography, elevation maps, and epithelial maps. And this can be useful, even pachymetry maps. So having an anterior segment OCT just an attachment can kind of help, even if you don't have a dedicated anter-segment topography like the MS39 or the Anterion, which are very expensive. They cost about 80-90 lakhs. So unless you have a very busy refractive surgery practice, it may not be prudent to invest in those. Ocular surface assessment is very important, and this is something you should learn to do before any refractive surgery, even before cataract surgery. So you have the ASCRS guidelines, you have the dues and the speed questionnaires. So this is something that you should learn how to do an ocular surface assessment, a TBUT and Sherma's. You can also use non-invasive TBUT to do a quick assessment, because the topography and the refraction can completely change if you have an ocular surface problem or dry eye. So this is very important in assessment in refractive surgery. So this is something that you need to learn. So when should you invest in a laser? This is again a question that should I invest in a laser? You started your practice, you're a couple of years into your practice, you're doing about 30, 40 cataracts, and you're getting few inquiries for refractive surgery. Then you're toying with the idea of investing in a laser. So again, there's a question mark, because what type of laser should you invest in? Should you invest in an excimer laser or a femtosecond laser that does calyx? This again, excimer laser will cost you anywhere. If you're going in for a second-hand laser, you can probably get one for about 1 crore, but a new laser will set you back by 2.5, 3 crores. For a femtosecond laser, which can do calyx, it can vary anywhere from 4 to 6 crores. So it's a very big investment. So if you want to invest in a laser, I suggest if you're getting about 30 patients a month for refractive surgery, then that's the time when you can think about investing in a laser, and then you will be able to kind of break even if you're at least have 30 patients a month. Before that, you can just kind of try to sign up for a facility utilization, because many of the centers, they allow visiting surgeons, they allow them to use their facility if they have some kind of refractive surgery training. Here you don't have to invest. You can take your patients there and then do the procedures, and once your practice kind of picks up, then you can look at investing in a laser. You also have group practice options. You 10 or 15 of you all can come together, young ophthalmologists who are interested in doing refractive surgery or who have been trained in refractive surgery, and then you can pool in money, and then this is a very good option, especially if you do not have the funds to invest. It reduces your financial risk. Nowadays, you also have pre-owned equipment which you can get at a lower cost, and the pre-owned equipment is quite good, even if they're older equipment, as long as the laser is functioning well and you're able to take a CMC contract, then you can give good results. You need not necessarily have the latest equipment. Of course, if you want to do a lot of marketing, if you want to market the equipment saying that I have this equipment, I have that equipment, then of course you can look at new equipment. But I always feel that you should market your skills as a surgeon, your results, rather than equipment. Because today you get an equipment, you market the equipment. Tomorrow somebody else down the street is going to put up the same equipment and then charge less. And that's something that you can't compete with. But you can always market your results, your expertise. And this is something that will stay for a long time. You also have hire purchase options where you can kind of pay in installments. Many of the companies, if you have a credible practice and good credit scores, then some of the companies actually invest, and they can kind of place a machine and they top up per procedure so that you're paying for the machine for every procedure. Of course, they will require you to give a commitment for a minimum amount of procedures, say 70 or 80 eyes, or even 100 eyes per month. And if you have that kind of an option and that kind of a practice, then that may be a good option where you don't have to kind of take a loan and then purchase the equipment. You can also have options for long-term lease, but these are basically offered for busy refractive surgery practices where the company will probably place the machine. They won't sell you the machine, but they'll just keep the machine, and then you give them a commitment, a minimum commitment of maybe like 100 eyes a month or so, and then pay them the fee, and they take care of the CMCs and all that. Because the CMCs are very expensive. They can vary anywhere from 25 to 50 lakhs depending upon your machine. And if you don't have enough number of patients, then this is a recurrent expenditure, not only your EMI, but the CMC. And also, suppose you don't use the laser, an excimer laser, you still have to do a gas exchange. So even if you don't have any patients, once a week, you have to do a gas exchange. Otherwise, the cavity gets spoiled. So these are all things that you need to keep in mind. So a laser is a white elephant. So unless you have adequate number of patients, you're confident of your refractive practice, don't get into it, because many of them have burned their fingers, they've gone into financial loss. So you should be very careful about deciding when to invest in a laser. Once you have your laser, you start your practice, then you will have to look at results. You will have to, of course, refraction and topography has been spoken about. You have your patient selection has to be meticulous. You need to also do a proper refraction, properly document your outcomes. Like I said, you always, even post-op, check the best corrected vision, check the refraction, and then document it so that you can have accurate data. You need this data for publications and for nomogram corrections. So you keep getting better by doing a nomogram correction. You know whether you're undercorrecting or overcorrecting. Some lasers are hot, some lasers are cold. So inherently, they can cause a little bit of overcorrection or undercorrection. Also, how you refract. If you're not pushing plus, then you can have overcorrections, and this is something that you have to learn how to do a proper refraction, and then a nomogram correction will further refine your results. You can have a percentage nomogram correction, and then that would probably give you like 80% of the benefit. Then you can have age corrected nomograms, and also for different surgeons, because again, from the time you lift the flap to the corrections, if you're waiting for a longer time, then you can have overcorrection. So your surgical technique also matters. So nomograms are different for different machines, different surgeons, different operating rooms, because the temperature, humidity, all that will affect your outcomes. And this is something that you need to learn. And like I spoke previously, the customizing to patients' need. So these early presbyopic patients, you should be very careful not to overcorrect them. You'll precipitate presbyopia. You also have to see what the patient's lifestyles are and what his hobbies and profession is, and then look at tweaking that. You'll also have to take patient feedback and monitor patient satisfaction. This is very important. Do it on a regular basis, because this will tell you whether patients are happy with the procedure. Because there are some procedures, again, the things that patients are afraid of are whether they will go blind, whether they will have pain, and whether they will get a good correction. These are three things. These are the fears that you'll have to address. So pain is something which can be there with some of the procedures like PRK. So you have to be very careful. If the patient has a lot of pain, then they are not going to refer other patients back to you. If it's a prolonged healing period, prolonged medication, that also reduces patient satisfaction. And the wow factor also is very important. Day one, if they're able to see well, then they're very happy. Then they tell all their relatives, friends, and then your practice keeps growing. And again, accuracy of correction. So what you promise your patients, and don't overpromise. Like many of these wavefront corrections, they kind of you invest in that equipment and you have a tendency to overpromise and say, I'm going to give you eagle vision, I'm going to give you 6:3 vision. But that's something you cannot promise the patient. And if the patient does not get that, they'll be very upset. And I would say, yes, don't market technology and equipment, because every other day the technology is changing. Then you have to keep investing to market that. What is more important is your results and your patient satisfaction, and that's something that uh, will give you better results if you market that. Of course, today is the era of marketing. When I started refractive surgery, then there was hardly any marketing. It was mainly word of mouth. Your happy patients used to bring other happy patients, and then the practice used to grow. But today, without projection, it's very difficult to sustain a refractive surgery practice. So there are different ways of marketing your practice. You have the traditional advertising and marketing route, like newspapers, paper inserts, cable TV, radio stations. They work well in tier 2 and tier 3 cities, but tier 1 cities, hardly anybody reads newspapers. So it may not be a very good idea. So you have to look at what works in your particular setup, in your particular practice, where you're practicing, and then decide on investing in marketing. Social media marketing is very important nowadays. Facebook, Instagram, YouTube videos. There are many practitioners who have, I think, got a lot of benefit by social media marketing. Their whole practice is based on social media marketing. And you should learn to do targeted marketing so that you cater specifically to people looking for refractive surgery. Otherwise, it's like a shotgun marketing, and then you're wasting your marketing rupees there. You should also project your specific services to colleagues and other doctors. If you're doing something special, if you're specialized in something, then you can actually project that through talks and conferences, through webinars, seminars. So this is something that you have to do as part of your refractive practice. So these are few of the points that I wanted to make for young ophthalmologists starting out on your refractive journey. So to conclude, you will have to identify your market and its needs, what type of laser you want to invest in, what are the type of patients you're going to cater, how much you're going to charge, whether it makes financial sense, and what kind of marketing tools you're going to use in your particular market. You have to keep updated on technology, because technology is evolving and there's a lot of marketing in technology. So you don't really know what works, what does not work. And the companies, they market the technologies, they sell you the technologies. Wavefront LASIK typically was something that, they promised eagle vision, and they charged you for the cards for every treatment that you did. They charged you for the technology. It was like buying a car and then paying for the meter to run it like a taxi, which was again very foolish, because if you looked at the post-op outcomes between normal LASIK and wavefront LASIK, there's not a huge difference. And that is something. So you have to use your scientific knowledge, your common sense when you're evaluating technology, and just don't fall for what these companies market to you. You actually evaluate whether it's good for your patient, whether it's going to improve patient satisfaction and outcomes. Start slow and upgrade. Don't put in all your money, buy the latest topographer paying 1 crore, buy the latest femtosecond laser, invest about 8 to 10 crores, and then you will also have to pay huge amounts for licenses, for CMCs. And if you are not able to get enough number of patients, then it becomes very frustrating, and you're going down a rabbit hole there. You will also have to enhance your marketing knowledge and skills. We are not taught this during our post-graduation. We are not taught about financial management. So these are all things that you need to learn if you're going to start a refractive surgery practice, and this will help you going a long way in your refractive surgery journey. So these are just a few of the points that I wanted to make. I welcome any questions, and I wish all my young colleagues a good refractive surgery journey, and I hope you all do very well. Thank you very much.
Thank you so much, sir, for sharing your decades of wisdom with us. So those were very, very practical pearls. To be honest, I had a list of preemptive questions to ask you, but I think your talk was so extensive that you already covered all of that. So I think, sir, now it would be better to just move on to the next talk, and we'll hold the questions for later because we are running short on time. I know you promised to stay till the end of the webinar, so I don't want to hold you here for too long. So I think we'll just move on to the next talk now. So it's my pleasure to now introduce Dr. Urvija Chowdhury. Madam is a corneal refractive surgeon. She's done a fellowship from Narayana Nethralaya in Bangalore. Currently, she's working at Indore at Raja's Eye Hospital. She's done a lot of work on topography-based removal of epithelium for the treatment of keratoconus. Madam is also the chief editor of Indore Divisional Ophthalmic Society Journal, a presenter at various national and international conferences, and she's also won the Best Paper Award at IIRSI. So, Madam is going to talk to us about the various options of refractive correction available to us today. A very tricky topic to navigate, but over to you, ma'am. I'm sure you'll do a good job.
Good evening, everyone. Am I audible enough?
Yeah. Yes, ma'am. You are audible. If you can get your mic up a little louder, that might be better.
Thank you, Yossi, for this opportunity. Dr. Sriganesh, sir, your talk was amazing. It's always such a pleasure to hear your talks, to hear your concepts on the surgeries and everything. I have been asked to give an overview about the refractive surgeries that are present in our modern day scenarios. So I'm just going to give a small overview of all the surgeries that are available to us nowadays.
Madam, your mic is a little not audible. So could you increase the volume? Could you speak a little closer to the mic if possible? So that might be better.
I'll try.
Yeah.
So is this one better?
Yeah, much better. Yes.
Thank you. So basically, the refractive surgery nowadays are cornea based and lens based, and we also have a combination of both. Mostly what we practice in today's decade are corneal based procedures like LASIK, PRKs, phakic intraocular lenses, and the upcoming trend is of the corneal lenticule extraction procedures as well. So the most commonly done surgery is LASIK, which uses an excimer laser and uses a short wavelength, and it works on a principle of photoablation where it reshapes your corneal curvature in a very sub-micron precision level with a very minimal collateral damage to the adjacent tissue. In LASIK, we have a selection criteria given by the FDA. It treats myopia, hypermetropia, and astigmatism, and it ranges from about -12 to +6 diopters with an astigmatism of up to 6 diopters. We can do it in any age of above 18 years where the refraction is stable for over a year. The minimum residual bed thickness of more than 250 microns is safe to be proceeded with, and we should also take care of there are no systemic co-ocular and ocular comorbidities. There are many contraindications for LASIK. It started with a microkeratome LASIK, and in initial times, surgeons also used to mark the cornea in case of free flap so they can put the flap back. So this is the marking which is done on the surface. The suction ring is being placed with a microkeratome head, which varies from 90 microns to 100 microns, 120 microns depth. Once you create this flap, it is lifted up, and after just drying the surface, excimer laser ablation was proceeded. So this was a conventional LASIK that was done. Then came femtosecond LASIK, whereas femtosecond laser was used to create the corneal flap. Femtosecond works on a photodisruption principle, and it is a laser-based procedure which is very, very precise. So it gives you very precise depth of the flap, and the flap is more snugly fit here because of the cut which is created by the machine as compared to the blade. It will help avoid all the blade-related complications. This is a vacuum ring which is being placed on the corneal surface. Once the vacuum is achieved, you will ablate the cornea and the laser, femtosecond laser is fired. It will create a flap. With the help of the gas bubbles, it will create a section, and you can lift this flap very easily with a spatula. And the rest procedure is same. You will fire an excimer laser to create the ablation. So this was the conventional, LASIK that is being done. The advantage of LASIK is has less pain, quick restoration of eyesight, faster recovery, less haze. But sometimes people do complain of halos, glare, dry eyes, reduced contrast. So with this conventional kind of excimer, which used to treat spherical and cylindrical errors, despite getting a 6/6 vision, some people face dissatisfaction with their 6/6 vision. Could be the reason being some residual high order aberrations or decentered optical zones, smaller optical zones because of lack of tracking errors. So then came different LASIK profiles like topography guided LASIK profile, wavefront optimized, wavefront guided. But to which would patient get the best result, you need to understand in depth the reason which we need to decide which one to pick for our patients. So if we understand there are some optical aberrations on the structure of the eye, which are not only the lower order aberrations, but we also have the higher order aberrations. So this is a aberration map that we see on our lots of diagnostic machines, where the green profile is the most ideal profile with the minimal distortion. It is a 2D analysis. The blue map is the myopic wavefront, like where the rays are focused in front of the retina, and the red is the hyperopic wavefront, that is the rays are focused behind the retina. So what we treat at conventional LASIK is the lower order aberrations, mostly the myopia, hypermetropia, and the astigmatic. But there are also higher order aberrations, mostly the comma, trefoil, and the spherical aberrations that does cause impact on the quality of your vision. Higher order aberrations above this are very less significant. So these profiles were mainly designed to treat these kind of higher order aberrations. In the wavefront optimized profile, it generally compensated the energy losses due to the peripheral pulses. So it was an estimated compensation done to reduce the induced spherical aberration. Second one was the wavefront guided profile. It is a very precise diagnosis of your complete eye aberrations from tear film till the retina, but at that time point, at that second, what your aberrations are, which are very dynamic. Your total eye aberrations will change with your tear film fluctuation, it will change with your accommodation, it will change with your age and everything. So it would just calculate that complete eye aberrations and treat them on corneal plane. So the disadvantages of wavefront guided were taken care with topography guided LASIK, because we know that cornea is a major source of our main refractive problems. Our major corneal aberrations are the cause of quality of vision loss. So topography guided LASIK usually analyze your surface of the cornea, and it would customize your ablation according to the irregularities on your eye. So it was a customized, personalized treatment given to a patient. It will measure any aberrated irregularities on the cornea and will reshape the cornea in a best fit A sphere, taking into account your sphere and cylinder also. So it was better than wavefront guided in the sense that the corneal aberrations are usually static. They don't change with accommodation. They don't change with your tear film. They don't change with age so much. They're independent of the pupil size. In topography guided, you're able to better get the peripheral data, because again, it's not pupil dependent. It's more accurate, more reproducible, and you are treating the corneal aberrations on the cornea, unlike in the wavefront guided treatments. So it also worked where the wavefront guided treatments were not able to capture the aberration profiles, like in highly aberrated corneas with corneal scarring, keratoconus, in patients with very decentered ablation zones, also in patients post keratoplasty and post RK. Contour revision treatment is a name given to a topography guided treatment only by Alhorn. And topography guided treatment is not only for your aberrated corneas or scarred corneas, because we know that even if you see the structure of the eye, so the refraction is not same throughout. There are minor variations throughout across the cornea, even if your refraction is like 1.25 diopters at one place, but it varies from point to point. The two astigmatism patterns are also very variable for two patients and also for two eyes. So this topography guided treatment analyzes these variations on the eye, and it will perform a customized treatment to give a more better quality of vision. Topolizer Vario is one such instrument which analyzes all the 22,000 points in the eye, and it creates a personalized profile, and this customized profile is then finally sent to the machine, and it gives a excimer ablation according to that. This was a very nice example given in one of the papers which I came across, and it shows a pre-op topography. And this is the post-op map, which is a very regular map. But to get this regular map, the ablation profile that was created was highly irregular. So this was what it shows, that how your irregularities can be treated and can give you a very regular surface. This is one such of our patient which showed the preoperative profile, the post-operative profile, but again, the same kind of irregular ablation, distribution of the ablation, which we see in the topography guided ablations to get a good post-op result. The most performed procedure after LASIK, I would say, is PRK, which is preferred by lots of surgeons nowadays. It reshapes your corneal surface not by making a flap, but it just removes the upper epithelial layer, and then it performs the ablation with the excimer laser. Suitable candidates for the PRK can be patients with thin corneas, who have for professionals, athletes, military personnel who have contact sports, and our chances of flap dislodgement are there. In patients with irregular corneas, and also for people who are uncomfortable feeling the flap-based procedures for their eye. This is a small video of a trans PRK procedure. You just numb the eyes with the eye drops, and as Sir said, PRK is just a one-button procedure, so is it. It's a one-button procedure. You remove the epithelium with the help of an alcohol or with the help of a trans PRK, that is with a laser. So here, first, the ablation will be performed to remove the epithelium. The tracking is being done. After the tracking is done, you can see here there are the pink spots, and then it turns into the purple spots. So the pink spots are when the epithelium is being burned, and then the excimer ablation is done to remove the spherous cylinder along with the aberration profile that has been captured on the topolizer. You just wash the surface and you place a bandage lens, and which can be removed after 3-4 days once the epithelium is healed. So the recovery is a little delayed here, because the vision improvement begins only after the epithelium is completely healed. There is a full visual recovery which may take up to weeks to months in this, and the post-surgery discomfort is more than LASIK. Like, patient does feel pain and sensitivity to light. There are side effects of dry eyes, light sensitivity, visual fluctuations, and there is a potential for haze and delayed regression and delayed visual improvement. So it's very important for a proper follow-up care after PRK, and using anti-inflammatory drops may reduce a lot of risks of haze and pain after the procedure. This is one of our patients where we operated a topo-guided PRK along with the cross-beam beam for him. So there was an improvement of UCVA, BCVA, the coma values reduced, and we had a very good post-operative result, and the topography looked like this. Now, this was one very interesting case which we saw in our clinic. It had a history of 2 ablative procedures done on the eye, or both the surgeries were done in US. And when we see the topography of the right eye, you will see that there is slightly decentered ablation. And the BCVA was 6/6. Sorry, the undercorrected, the unaided visual acuity was 6/6. But patients still complained of distorted images, glare, halos, which was more in his right eye. And he was given lubricating drops, and since 2 years from all the doctors that he had visited, lots of lubrication and all kinds of treatment for MGD was given to him. When he came to us, we also did the same. We also tried to help him with lubricating drops and some dry eye treatment from our choice. But he was very insistent on that I had problem with my vision and I want some treatment for this. So this was going to be his 3rd procedure. There was an irregular flattening seen here in the 3 mm optical zone area. And it was coming in his optical zone. That is why it was creating all the visual distortions. When you see the eye trace map here, you will see in the right side, there is a high coma, high spherical abrasion, high trefoil. Even in the 3 mm pupil area also, there is a high order abrasions. The total high order abrasions were 0.9, even the corneal abrasions were above 1 micron. They were not so in the left eye. They were still high, but he had main complaints from the right eye. So we decided, let's do the right eye first. And if it goes well, then we'll go for his left eye. So actually, he benefited from a topography-guided treatment. His topography topalizer was analyzed. The topography-guided treatment was done. And when we evaluated him after 15 days, his simulated vision also improved. His higher order abrasions went down from 0.9 to 0.1. And he was really happy about this. So it's actually a good treatment for patients who actually have higher order abrasions, who have irregular corneas. The quality of scans need to be very, very good once you plan the treatment. And it can be a 2-step procedures also in high order abrasion cases, like irregular corneas. You can just do a topo-guided treatment for them first, then measure the lower order abrasions, his spherocylinder, and then go ahead and plan the complete refraction in the second week. After the LASIK and PRK, nowadays there is a trend of corneal lenticule extraction procedures, which again is a femtosecond based procedure. Here the lenticule is created and it is removed, which will alter the curvature of the cornea and correct the patient's refraction. It's indicated in myopia and astigmatism. It's still not done in hypermetropic patients. There are various companies and various names by which lenticule procedures are done nowadays, like Smile, Silk, Clear, and also Schwind Atos has this procedure nowadays. There are 2 kinds of lenticule shapes that are being provided in these lenticule procedures. One is the biconvex shape, other is the planoconvex shape given by different companies. The advantage of the biconvex shape, what I understand here, is that the lenticule edges, as seen in the Smile procedure, Clear procedures, are quite high, whereas in the biconvex shape, the edges of the lenticule are deeper inside. So it not in the area of where the corneal nerve density is higher. So it's not interacting with so much of corneal nerves as in the planoconvex surface. So it would give a lesser dry eye, more biomechanical spread. Similarly, the biconvex shape, it's a symmetric shape, so it easily fits in the biconvex shape. It matches perfectly and therefore giving less corneal distortions and less induced aberrations. This is a small demonstration of machine also for the marking. After the marking is done, patient is shifted for the procedure. You just mark the 180-degree axis. And this is how the interface would look like. This is the interface of the machine, which is quite simple and intuitive and makes the treatment planning very easy. Here we are planning a minus 2.75 sphere with 0.5 cylinder. A nomogram adjustment has been done. It also gives you the complete picture. The lenticule system checks for any tilt or variation in the cone glass. This is a very important step as this will account for any variation in the glass and can ultimately affect the result or the dissection of the surgery. We can use the joystick to adjust the machine, and this is the second part of the PI, the suction ring, which is being placed on the eye. It is connected to the system port from where it generates the vacuum. The suction ring here is used to fixate on the eye, and once the centration is fine, the vacuum is instantly achieved. Now you use the joystick to lower down the applanation cone onto the ring. Once the cone fixes onto the ring, you check for the optic position indicator on the right side as it comes on the green zone. Somewhere in the middle, not very low, not very high. Now you pinch the suction ring and the cone applanates the cornea. The meniscus should go beyond 10 millimeters to give you a wider area for adjustment. Now you lock in this position and go for the centration and the cyclotorsion adjustment. It has got a very good touchscreen mode, so you can do it by yourself. Now the laser treatment is started by moving a raster scan line in a radial pattern. It resects the posterior surface of the lenticule first, then the side cut, and then the anterior surface of the lenticule is cut. At last, it creates the cap cut. And within seconds, the treatment is completed. Now you undog the patient and shift it under the microscope. By using a separate microscope from the wetting the surface improves the visibility a lot. Then we enter the cap. Try to find the anterior and the posterior plane. This is the tricky part. If you find the anterior and the posterior plane, your surgery becomes quite easy. So the trick here is to tent up a dissector a bit and enter the anterior plane, and while entering the posterior plane, dip in a little because it's a biconvex lenticule. When you enter the posterior side of the plane, you will see that due to the opaque bubble layer, the clarity is slightly reduced, and when you are entering the anterior surface, the clarity of the instrument is quite good. In a windshield wiper manner, you dissect the complete lenticule till the edges. Then you try to enter the posterior plane, and in the similar windshield wiper manner, the posterior lenticule part is also cut. You may find little resistant at the 3 o'clock and the 9 o'clock position, as it helps in preventing the rolling over of the lenticule. Once we are sure that the lenticule is completely dissected, with the help of a forceps, we grip the lenticule and pull it out. Quite fast. Recovery by 24 hours. So the corneal lenticule extraction procedures are flapless and painless and bladeless. So it's minimally invasive. It gives a faster recovery and the patient can resume mostly all the activities by 2 days. It's good for people with contact sports and because there are no chances of flap dislocation here. It's a small comparison of all the topography guided basics and lenticule procedures. Visual recovery is definitely a little slow in lenticule-based procedures as compared to LASIK. It's slowest with PRK although. But topography guided gives you the best and the sharpest vision because it tracks your cornea and it calculates 22,000 points and it gives you a better correction. With the lenticule procedures, hypermetropia still cannot be performed. The topography guided LASIK will give you a better and sharper vision because it's planned on the visual axis as compared to the pupillary axis treatment done with the lenticule procedures. With after the LASIK PRKs and the lenticule procedures, there are still patients in which who are not fit for these procedures. For them, we have phakic intraocular lenses, which are placed inside the eye in front of the patient's natural lenses. There are different lenses. The advantages are that it is a reversible procedure. If the patient has any kind of trouble or side effects with the procedure, it can be taken out. It has no structural changes that are induced in the eye as in LASIK that we do. It gives a very good quality of vision. It does not reduce your contrast sensitivity at all. And we sometimes even see there is improvement in the BCVA of the patient. The recovery is very fast. It preserves your accumulation. This is a small video of a phakic eye being implanted in the posterior chamber. Once you make the side ports, the main bone needs to be slightly larger, around 3.2 millimeters. Then you inject Helon. Helon will give a better stability of the anterior chamber and it will be easier to remove after the ICL is implanted. This is the lens with the central flow, which helps in flow of the aqueous and it prevents increase in dioptry after we implant it. You need to handle it very carefully. It's a little fragile, soft. Once it's taken in the cartridge, you inject it very.
Dr. Urvija, we are running slightly short of time, so can we not? Yeah.
This is a small video for the ICL. It's indicated for patients where LASIK is not the procedure of choice. The anterior chamber depth needs to be more than 2.8, and the endothelial count needs to be more than 2,000 to 2,500. Refractive lens exchange is one such procedure which can be useful for the patients who are even unfit for phakic IOLs, who have developed early lens changes due to myopia, and some people who also want presbyopic correction for them, and they're just not happy with your distance vision correction. So these are the overview of the procedures that we have today, and thank you everybody for giving this opportunity.
Thanks, Dr. Urvija. That was really, a very good overview of all the procedures, and you nicely showed it with, lenticular. With your videos as well. So I think Aditya you'll introduce the last speaker. We'll go ahead with the last speaker, and then we'll take discussion at the end.
Yeah, let's do that. Dr. Urvija, could you stop sharing your screen just for a minute? Yeah, thank you. So it is my pleasure to now introduce the next speaker. The next speaker would be Dr. Doda Lakshmi Priya. She is doing her cornea and refractive surgery fellowship at MNI Hospital in Chennai. She's got multiple publications in PubMed index journals. She's also made multiple presentations in various state-level conferences in TNOA. So Dr. Lakshmi Priya is going to speak to us about an interesting topic, whether a surgeon needs to undergo a refractive fellowship training before they start performing refractive surgery. So I think Dr. Nishant is also here in the webinar, so I can take a good guess as to how this presentation is going to go. So Dr. Lakshmi Priya, you can share your slides.
Yes, sir. Is my slides visible, sir?
Yes.
Thank you, sir, for the warm note. And it's a privilege to present here with everyone in this platform. So I'll be talking about refractive surgery fellowship, if it is needed or not. So basically, what is the art of learning? So we all know that learning is a process where we develop the skills and also improvise our knowledge. So as a budding ophthalmologist, it is very important to utilize this time period. So here, what is dexterity? So basically, it is more like motor skills. So in this aspect, we tend to learn and figure out by ourselves. So it is more like a trial and error method where we make mistakes, we realize and we improvise based on the situation. And also in this method is more like our expertise have come across this phase and also developed to an outstanding position that they are in now. So we as a budding ophthalmologists, we have the privilege to work under them and under their guidance and also help to improvise in a better way. So the second method is by tips and tricks. This is as we have mentors and guidance with everyone around us, we can easily interpret and also intervene the situation, and also with a guide you can develop your boundaries of thinking in handling many situations. So the next important part of art of learning is decision making. It is more like a psychological process. So in this situation, self-confidence is very important, and it is very important to handle the situation or the case which you're dealing with. With a mentor, you have the privilege and you're more fortunate to observe how they are taking care of the patient or how they're dealing with the situation. And also, you can gather valuable points, and also it will help you to combat your situation in a simpler manner. So this is a scale which is showing how you can become an expert. So here you can see the graph which goes from a novice to an expert. So all this is, it depends on how competent you become and how proficient you are in taking any decision and how you can also interpret any situation. So down you can see that the distribution scale from a novice to becoming an expert is about 10 years. So if you have a guidance and you're doing a fellowship, the time period is much lesser because you have someone who's always going to tell you what to do or like make it more simpler for you. So in that way, it is the period of time is also very shorter for us. So having a mentor, you can basically learn from expertise, which will help you to develop your skill and have a guidance on various modalities, and you'll have a very good support system behind you, and they'll also help you set up a goal and you'll know how to go further with what you're doing. So coming to the clinical exposure, definitely your hands-on exposure will be really good because you'll have your surgeries will be performed under supervision, and you will get to learn newer techniques, and in this way, because you have a guide, you'll be more competent and you'll be more confident in what you're doing. So coming to the technology, when you're in an institute trying to learn, you'll be exposed to many advanced diagnostic tools and you'll become more proficient in how to diagnose and how to interpret the situation. So you can also acquire or enhance better skills. So what is very important, as discussed earlier, it is about patient communication. So it is very crucial to make the patient understand what you're trying to treat, and how to explain complex medical information in simpler terms is very important. So you should ensure, like how sir mentioned, refractive surgery, you should post-operative about the best corrective visual acuity is very important to analyze and tell them how it is going to be. So about enhanced patient management skills also you will be learning. So you can assess the patient thoroughly and develop various treatment plans. And also what is important is you'll also get to learn post-operative care, how to counsel the patient, and also very high patient satisfaction. So another important point and benefit that you have is research opportunities. You can try new studies and also various comparative analysis or retrospective studies. And also there are various comprehensive knowledge of many eye disorders. You'll have a knowledge from an expertise, and you can accurately diagnose and treat the condition. So few tips that can be noted during a fellowship period based on your preoperative, intraoperative or postoperative period. So in preoperative, as we all know, the basic evaluation is visual acuity, AR and acceptance, and non-contact tonometry, and basically tear film analysis and X-ray scan and fundus evaluation. So what is more important is the background profile of the patient, like what is the need for LASIK and what is their career, if they're an athlete or any sports person. And also very important to obtain the consent form and explain the details about the best corrector visual acuity. And also you should counsel the patient that maybe after the age of 40 years, they will require near vision glasses, and also like there can be development of cataract, because the patient should not come back to you questioning. So all this communication skill is very important that you can also learn by looking at your eye. So the other parameters to be noted is to check the fluency when doing the procedure, the foot pedal assessment, all that is important, and also the ring size and the blade size. So it is very important to enter your own data, and also the preoperative refraction, all that should be checked properly. And other factor that is also important during the intraoperative period is the humidity and temperature. So coming to the intraoperative period, you need to dry the conjunctiva completely and also mark the cornea. Also, you need to assess the sister's foot pedal of the suction when you're doing the procedure. Make sure that they understand the procedure before doing it. And if you suspect anything, you can always stop. And also, if you have a guide, they'll be there to assess and they'll be behind your back all the time. So post-operatively, it is very important to meet the patient and the attender, explain the situations, and tell them what are the other symptoms that they can come across. And if they have any pain or anything, it is very important to assess the pain scale, and a proper slit lamp examination should be done. So basically, with the fellowship, you can actually plan effectively, analyze efficiently, and also you can implement appropriate procedure and necessary treatment, which will in turn lead to patient satisfaction and self-confidence. Thank you.
Thank you, Dr. Priya. So, that was also a very good presentation. Definitely, I think, we have a lot of surgeons who are confused whether if they want to start refractive surgery, whether a fellowship is really important, short-term training is required, or whether some people feel that you can just start it like that only. Definitely the message that goes out should be that, if not a fellowship, at least some sort of formal training is really required. And I would like to ask Dr. Sri Ganesha, since he's one of the runs one of the most successful refractive surgery fellowships. Do you feel that someone who is, say, not into the practice of even cataract surgery, some other specialty, practicing purely oculoplasty or squint or retina, wants to start refractive surgery practice? So, like, do they do a short-term training, or do they do a formal fellowship?
Again, it depends upon why they want to do refractive surgery. If it's just to earn some extra money on the weekend, just do a few cases, then it's not a specialty. I started off like a pan-ophthalmologist. I used to do everything from retina, squint, glaucoma, corneal transplants, even orbitotomies for orbital tumors. But then later on, you can't really remain a pan-ophthalmologist. This is the era of super specialization, and you need to specialize. And refractive surgery is a highly specialized branch. Even evaluation and then giving the option to the patient is all very important. So I think it is being a weekend warrior or a weekend refractive surgeon is not very professional. And if you want to be a top professional and give the best to your patients, then it's best that you do a fellowship. You can do a short-term training if you're a general ophthalmologist. If you really want to get into refractive surgery, you don't have the time, you don't have 2 years to spare, then you can do a short-term fellowship, at least to learn the basic ropes of refractive surgery so that you don't do any harm to the patient. And if you are really interested in doing refractive surgery, and then go along that path. But definitely it needs some expertise, it needs training, it needs that you learn everything about the instrumentation, the pre-op diagnostics.
So I think we just move on to the questions that are pending that some of the participants had asked. I think Dr. Urvija Chaudhary had a question to ask Dr. Sri Ganesha. I think Madam is here. Can you just tell us your question, ma'am?
Your mic is very low.
I think Madam is muted.
No, we can't hear you.
Okay,
Anyways,
I
yeah,
think I'll just
yeah,
read out the
yeah.
question then.
Read the yeah.
So, Madam had asked, do we check the near vision before finalizing the distance refraction of up to 6.5 or 6.4?
The near vision also is important because see, you have to check the distance, best corrected distance vision, and the near vision in patients who are pre-presbyopic or presbyopic. Then they should be comfortable with the near vision also. In very young patients who have very strong accommodation, it may not be that important, but in pre-presbyopic patients, after you give them the full correction for distance, you need to check the near vision and see if the near vision is compromised, so that you can do a mini monovision or you can do a slight undercorrection so that they're comfortable. Because today is the era where most people are on their mobile phones, and you do a perfect correction for distance, and then you suddenly they become presbyopic, they're not able to see their mobile phones clearly, then they become very unhappy. So this is something that you have to keep in mind. You have to check not only the near vision, you also have to check the ocular motility and muscle balance, extraocular muscles. That's also very important because some of them may have problems. They may have hidden squints. They may have convergence insufficiency. They may have fusion issues. So it's very important to check this because that can get unmasked after the refractive surgery, and they can be unhappy.
Thank you, sir. So the next question was from Dr. Richika Abraham. Madam was also asking whether there is an inherent advantage on using phoropters as opposed to using a traditional trial frame.
Yeah.
Does it affect the final manifest refraction?
Yes, because see, with the phoropter, what happens is the back vertex distance is fixed. Okay, and the lasers, normally when you put in the refraction, for the lasers, it's a back vertex correction of 12 millimeters. So when you use a trial frame, again, depending upon the configuration of the face and nose, the back vertex distance can vary. And this can have a big influence, especially for high refractive errors. Suppose you have a high myop, like a -8, -10, and you're not kind of keeping that back vertex distance exactly at 12 millimeter, then you can either have an undercorrection or overcorrection, whether depending upon where the lens is placed. So with a phoropter, it's kind of fixed, and it's much easier to flip through lenses and for the patient to kind of see the subjective refraction as to which is better. So these are the two advantages using a phoropter. But if you're using a trial frame, you should ensure that the back vertex is around 12 millimeters, especially for higher refractive errors. Otherwise, you'll get into trouble.
Nishant sir has a question, I think.
Yeah. Nishant.
Thank you. Amazing session, Altriya. So nice to hear all the points from you, Sri Ganesh sir. Just two questions regarding the contact lens, which you said. So even today, in this era where the contact lenses are really good, the DK value is high, do we still wait for the scans? Because what I do is some people come with the contact lens. I remove the contact lens, I take the scans, and once again, during the procedure, I tell them 5 days they have to be without it, and I repeat the scans. But I don't find so much of a difference. At least we know that they are fit or not to undergo the laser. So is contact lens a pure no-no for evaluation, or we can repeat it just before the day of the procedure for re-evaluating the values? That is one question. The second question is, I always see OU vision, that is, it's always both eyes. So what is the take on that with the whole group? Because I still have patients when I used to do before they said, sir, so long I was seeing nice. Your optometrist told me to close one eye and see. I found that one is 6/6, one is 6/6 parts. So from that time, my hospital, my refractive surgeries, all my patients are both eyes vision only. What is the take on that, sir?
See, regarding the contact lens, see, if the patient is wearing a daily disposable, the daily disposable is very thin. Okay, and then the Corneal warpage is not much. So you may not have much of change in the refraction. But sometimes, see, these have a standard base curve. Okay. So you're not actually measuring the cornea and then fitting the contact lens. The disposable lenses come in standard base curves. So if you have a very steep or a very flat cornea, what happens is you can have epithelial changes. And this can affect the refraction, and it takes almost 2 weeks. So if you're doing epithelial mapping and you see that the ocular surface is not affected, the epithelium is kind of uniform and normal, and the topography is normal, then you can probably even proceed earlier. But you have to have all these tools. I had one patient, in fact, ophthalmologist, daughter of an ophthalmologist, and he referred her for the procedure. And we did the refraction, and she was accepting. She just removed her contact lenses. She was accepting about half a diopter more than her spectacle, which she was wearing. She was not wearing the spectacles regularly, but she was wearing contact lenses. She was wearing the disposable contact lenses, but her cornea was quite flat. It was like about 40.5 diopters. And when you wear the standard fit, then it's a steeper fit. So what happens is the epithelium gets heaped up in the center, and then this can kind of increase the myopia. And that's why when we did the refraction, it was about half a diopter more than her spectacle power. And then we are asked her to be off the contact lens, use lubricants. Saw her after 10 days, and the refraction had settled, and then she was accepting about 0.5 less, similar to her spectacle. So it's very important to check the spectacles they're wearing. And sometimes, when they just remove the contact lens and you refract them, then you can have this difference. Because her cornea was quite flat, and then you put a steep lens, then you have this effect on the epithelium, which kind of tends to get heaped. So these are all small changes. Even ocular surface also. Ocular surface, if you have many of these contact lens wearers overuse the contact lenses, and they have some ocular surface problems. They have dry eye, and the astigmatism can change. You can get up till 3/4 of a diopter, 1 diopter change in the astigmatism. So you don't, because it's a permanent correction which you're doing, you want to be as accurate as possible. And if you tell the patient, you show them that they're not going to run away to your neighbor if they're in a hurry. You tell them that, see, this is something that you're going to do once and you want to get it right. So we want to be as accurate as possible. And you explain the reason why they have to be off contact lenses, and they'll understand and be off contact lenses. For your binocular vision, see, when you do a binocular vision test, there is summation. So binocularly, the vision is better than monocular. That's because of summation. But when you want to get your nomograms right, when you want to know your correction, when you want to check the best corrected visual acuity, you have to check it monocularly. Then you will know actually as to what correction you have done. Because sometimes it may just be like 6/9 in one eye and other eye 6/6 parts. And then you make them read binocularly, they are reading 6/6 or even 6/5 parts. Okay. And then you say everything is fine, but then you will not really know what their correction is, whether your nomograms are right or wrong, or whether your laser fluence is okay. So if you want to actually give the best results, if you want to fine-tune your laser, if you want to fine-tune your results, then you need to check monocular best corrected vision. And it's not that if you're not promised the patient, and if you have counseled them properly beforehand that yes, it's plus or minus 0.5, we're just checking. You don't need glasses, we're just checking. And then you tell them, we tell them also, you have 0.25 cylinder, but you don't need glasses. And that's fine, because for 0.25, you don't prescribe glasses. And you tell them that it's your uncorrected vision, and whether your vision is good enough to do all your normal tasks, and they are fine with that. So being honest is important. And if you just make them read with both eyes, then they go to some other practice and they say, your one eye is undercorrected, and didn't the doctor tell you you only have 6/9 vision and all that, then they'll be very upset with the practice.
Yes, true, sir. Thank you. I do an AR check and also take some scans, but yeah, I look into it. Thank you.
And if you want to publish data, then you need proper data.
I can't. Yeah, that's the problem. I know.
can't.
that is
Sir, as a follow-up to your talk, I have 2 questions. So for a young ophthalmologist now to afford the newer technology, would a group practice, a group funding be the right way to go about buying a new equipment? And the other thing about laser specifically, are Alzheimer's on the way out? Should a young ophthalmologist go straight away for a lenticle extraction technology, or will the Alzheimer's still have its role in the refractive armamentarium?
Yeah, that's a nice question. See, group practice is something that you can do, but again, all the people in the group should have a proper mindset. You should have a very clear understanding as to how you are going to share responsibilities, how you are going to share profits, how you are going to share expenditure. If this is not there, then again, you invest, and then there is some amount of disagreement, and then the whole thing goes for a toss. There's litigation, and it can be worse. And that's the reason why people are hesitant to get into a group practice, because it's you need to have a thorough understanding, and then only will it work properly. I've seen group practices fail because the partners there are not in sync, and one person is doing more surgeries, the other is doing less, but they've invested equally. Now, how do they share? There's so many other issues which come up, and if the center is not earning enough, then who is going to take the expenditure? Whether you're going to put in money for the expenditure. If it's your own practice, then you can kind of, anyway, you're going to run it by even spending money which you earn from your cataracts. So that is there. But yes, it will reduce your financial burden. What type of laser you have to invest, again, totally depends upon where you're practicing. And if it's in a big city like Chennai or Bangalore, where everybody is advertising about the latest techniques and all that, then you can. But even with a microkeratome LASIK, with a standard laser, you can get very good results. And most of this, topo guided, wavefront guided, all this is required only in about 0.5% of patients. 99.5% of patients, you do a wavefront optimized LASIK, and you do a good job, you do a thorough refraction, then you will get very good results. There's no point doing a wavefront guided or a topo guided if your refraction is not proper. If you don't know how to refract and you put those values, and you're doing a topo guided or whatever, the results will not be good. Or if you don't know how to reposit the flap, there are microfolds in the flap, your surgical technique is not good. Even if you're using the best equipment, it's not good. So don't depend on equipment. Learn the proper primary skills of doing a refraction, surgical skills. They're very important. And there's a lot of BS marketing going around. That's something that this cannot be the wow factor with lenticule extraction is not as good as topo guided or wavefront guided. It is BS. We see patients who are 6'4" on day one. If you have optimized your laser, if your dissection technique is good, you can get excellent results. Even the quality of vision is very good. So it's not that. And there is unsubstantiated marketing today happening by companies. The biconvex lenticule is typically an unsubstantiated BS, because all lenticules for myopia are biconvex. That means they are thicker in the center and thinner in the periphery. And the corneal tissue is flaccid. You put it on a table, it will become plano-convex, right? Or if you hold it up, it will become the other way around because it is flaccid. So you're just removing that much of tissue in the center and that much of tissue in the periphery, which is going to correct the refractive error. And there are absolutely no studies which show that the corneal biomechanics is better or dryness is less in a biconvex lenticule. And anyway, you are applanating the cornea. So when the cornea comes back into its normal position, it's no longer the biconvex. Once you remove it, it's just an interface. Once the tissue is gone, and there's no difference in the corneal shape. Finally, the refraction depends upon the air cornea or air tear film interface, right? It doesn't depend upon the interface in the stroma. So we should use our common sense as ophthalmologists and a knowledge of optics and tissue and not fall for this BS marketing, because these companies will market because they want to push their product. But you should use your common sense and understand the technology and see whether it's actually making a difference or not. They tell you something and you again start talking about it, and it appears very foolish, especially when you're talking to people who know the subject or know what they have been doing. Because this is something which I tell all the youngsters, that don't again do marketing. Typically there are some, like the companies when they came out with the Symphony lens, also the first study they said there's no glare, no halos, night vision is perfect. But once you put in the lenses, patients were coming back with night vision issues. So you can't 100% depend upon what the information given by the companies. You need to look at peer reviewed literature, publications, scientific publications, and that's how you should actually talk scientifically. So this is something that you need to kind of understand. And what I would advise my young friends is learn the foundation, the basics properly, how to do a refraction, the surgical technique, and you will find that 99.9% of your patients will be very happy. You don't need that kind of technology also.
So I think the take-home message is whatever you're doing, whether it is surface ablation, LASIK, SMILE, phakic IOL, whatever is in your hands, the technology that you have, do it well, you will get good results. That's about
Yes,
all.
even see, phakic IOL technology is a non-wavefront technology,
Yeah,
and more patients have better than 6x vision with phakic IOLs than with wavefront guided or topo guided LASIK. Agree with me?
correct.
Yes. So it's a non-wavefront technology.
So what would you say to a practitioner who says, okay, I don't have access to a excimer or a femtosecond laser, but I do a fair amount of cataracts. I'm just going to start my refractive practice by implanting fake IOLs in all my patients. Is that
You
real?
can do that. You can, but you are restricting yourself.
Yeah.
So ideally, you should have all the instruments, access to all technology, so that you can offer the best to your patients. Suppose you have a patient with a shallow ACD,
Yeah.
or the periphery is quite shallow, then you can't do a phakic IOL. Then you can, of course, if you don't want to invest anything and you just have a cataract practice, you want to start refractive surgery, it is a good option. If you're a skilled surgeon, you can get very good results with phakic IOL, even in lower powers. But the biggest problem is sizing there. And
Correct.
that's why you don't want to kind of use it for all patients, because you can have issues. About 2% of patients may require exchanges. And long-term, younger patients, of course, the risk of developing cataract is also their atogenic touch, or the vault is low, which you can't 100% predict. So that's where corneal refractive surgery also has a place. So you
Yes.
should be good at everything. And there are some patients who have basement membrane dystrophy. These are patients whom you don't want to do LASIK or SMILE. You would prefer to do a PRK. So there are specific indications for different procedures. So you should be good at everything so that you can select the best for your patients.
Great. So any final comments from Zain, Nishant, anyone else from the audience?
Thank you. Like you said, people who don't have access to all the machines should be friends, like how I'm friends with Aditya, where I go and do smile. So I will say that never say no, like what Sri Ganesha says. Have access to all technologies, either by yourself or by the people who have them. It is now possible to go just operate. I think that will be my final take.
Yeah, I agree. I mean, I think the take-home point for me would be to, hone your skills in refractive surgery rather than just talking about technology. I think that's a very, well taken point. And I think overall the session was, though a bit long, it, had very good pearls for young ophthalmologists wanting to start refractive surgery practice.
Yeah. So I think we only about overshot by 1 hour and 15 minutes. So, so let's bring this webinar to a close and
Thank you.
let Dr. Sri Ganesh sir go back.
Amma.
So I'd like to thank you all. Thank you, sir, for spending your valuable time with us on a Sunday evening. Thanks to the YOC Governing Council for letting us have this webinar. Thanks to all the speakers who came here and spoke so wonderfully. They all spoke so well. Thanks, Zain, for helping me to bring this webinar together. And see you all next time for episode number 2 of Path to Precision.
And
Thank
also Manjula from Numurotech.
Of course. Yeah, that goes
Thank
without
you.
saying.
Thank you.
Yeah.
Thank you, Altria. Thank you, everybody,
you.
and have a good night.
Thank you, sir.
Good
Thanks.
night.
Thank you,
Good
sir.
night, sir.
Good night. Yeah.
Thank you. Thanks, Manjula madam. Once the YouTube link comes, Aditya, you can share.
Done. Yeah, I'll do that. Right. Thanks, boss. Thanks for
Thank you.
coming.
Bye. Bye. Good night. Bye,
Bye.
Zain. Priya, good talk.